We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar MLC, organized by TNFOG. So it's my privilege to introduce the MOC of today's webinar, Dr. Gayatri N. Ma'am. Ma'am is the consultant at Shamla Nursing Home, Trichy, and executive member of Triox. I welcome you, ma'am, and I hand over the session for further proceedings.
Thank you very much, Sahiti. Can thank you. First of all, a warm welcome to all the delegates and thanks all faculty for taking time to join us and enlightening our delegates. I call upon Dr. Sampath Kumari to give an introduction about what is this marathon CME meant for, etc. Dr. Sampath Kumari requires no special introduction as she is quite well known everywhere. Despite it, let me not neglect my duty. She's been the Vice President of Foxy 2022, a Senate member in the Tamil Nadu Dr. MGR Medical University.
Yes.
Okay, ma'am, over to you, ma'am, to introduce.
All the delegates, welcome our Chief Guest Lakshmi Madam and our President Dr. Ramani Devi and all the delegates and faculties. This TNFOG Marathon CME is conducted by TNFOG. This is the third year we are conducting. Every month, second Friday, we will be conducting. We'll have one topic as our theme. Today's topic is medico-legal issues. So in this, we have 3 sessions. First session is your session. They will be presenting 12 minutes and we will have a standard judges. They will ask 3 questions. So only it is called as Marathon CME. In our annual conference, the best your orator will be awarded the prizes. And the second CME will be update on the same theme. Today we have Jitendra Sharma sir for our update. And third, we have the medical legal cases, the panel discussions on the same thing. So after the second and third session, one questions will be projected for delegates. Whoever is answering first, they will be given a small prize like BP apparatus, glucometer. That is the reason we have named it as Marathon CME. Now I welcome our President Dr. Ramani Devi Madam to give the welcome address. And Tamil Thai Valthu Podla Sahiti. First you may put the Tamil Thai Valthu and then we can invite, Gayatri can invite Ramani Madam. Thank you.
Thank you, Sahiti. Can I have Ramani Madam's CV?
1 minute, 1 minute.
Yeah. I invite Dr. Ramani Devi, who is the current president of the TNFOG, to welcome the delegates and introduce our chief guest today. Madam, again, requires no introduction.
Gayatri, that is enough. respected chief guest, Dr. Lakshmi Srikande, who is the past chairperson of ICOG ICOG, as well as the past vice president of Foxy. I have great pleasure in welcoming you for this August meeting and the very important topic of medical legal issues. I am also very happy to welcome Dr. Sampath Kumari, who is the founder secretary of TNFOG. And as she has in detail explained what is the purpose of having this Yuva session and a marathon CME, I welcome the two judges, Yuva judges, Dr. Shanti of Savita Medical College and Dr. Kartika Prabhu of SRM Medical College. And today we have two Yuvas, that is Vasanthi Senthil from Dharmaburi and Dr. S.G. Vijayalakshmi of Coimbatore Medical College, who are going to present their short talks for 12 minutes on this medical legal issue, that is MTP Act, POXO Act, etc. And I have again a great pleasure in welcoming Dr. Jitendra Sharma, who is a medical legal expert and past vice president of Foxy. He is going to deliver his very nice talk on mob in the labor ward. Then again, we have a reverse panel that is being moderated by Dr. Vivek Madi on the topic of medical legal issues, what currently the doctors face, and also the faculties for that, Dr. A.R. Shanti, Dr. Gayatri N, Dr. Gayatri S, Dr. Chandrakala Maran, and Dr. Geeta, and Dr. Radhika Gauri. And everything will be I also welcome the MOC of today's program, Dr. Gayatri. And no CME will be complete without the participation of all the delegates. So on behalf of TNFOG, I have great pleasure in welcoming starting from the chief guest up to the faculties and the delegates for this very important CME on medical legal issues. Thanks for the opportunity.
Ramani madam, you can introduce Lakshmi madam. Sahiti, yes. Lakshmi madam, CV podu.
CV. I have again immense pleasure to welcome Dr. Lakshmi Srikande, who is the immediate past chairperson of ICOG. She is the national corresponding editor of Jogi, a national corresponding secretary, Association of Medical Women of India, joint secretary for Indian Menopause Society, vice president-elect of ISOPAR, president of ISOPAR Vidarbha chapter, chairperson IMS Education Committee, and chairperson Fertility Enhancement Committee of ISOPAR, member Tnfog Education Committee, president of Association of Medical Women of Nagpur, and president Menopause Society of Nagpur, senior vice president of Foxy, president Nagpur OBGYN Society, and she has been honored with Fellow of Royal College by RCOG UK, and she has received many awards. Nagpur Ratan Award by the Union from the Union Minister Sri Nitinji Gadkari, and then received the Bharat Excellence Award for Women's Health, and she got the Best Committee Award when she was the chairperson of HIV/AIDS Committee of Foxy in the year 2007 to 2009, and received the appreciation letter from Maharashtra government for her work in the field of Save the Girl Child, delivered 32 orations and 550 guest lectures, and she has 62 national publications and 31 international publications. She has sensitized more than 2 lakh boys and girls in the adolescent health. And more than everything, she is a very, very humble person and a dear friend of TNFOG, me and Sampath and almost all the office bearers. With this warm introduction, Dr. Lakshmi, I welcome you to this forum and you deliver the chief guest address. Thank you.
Thank you. Thank you so much, Ramani, for such a warm introduction. And I must say that Ramani, Sampath, you all are dear friends from many, many years we know each other. And I'm so happy to be here once again on the TNFOG platform. It's a very vibrant and dynamic organization doing wonderful work. And I'm so impressed when Sampath outlined the concept of today's marathon CME. Sampath, as I know, lot of webinars are conducted on medical legal issues, but still we have to go on repeating, revising the knowledge, and we have to go on updating our own members, because all the issues you have chosen are really very, very practical, required in our day-to-day practice, starting from examination of victim, because each and every gynecologist, whether they are in private sector or in government sector, they should know how to examine the victim, because you just can't refuse. So I'm impressed with that topic. And of course, the recent amendments of MTP Act, still many members are confused. POXO Act, yes, in the context of MTP and other context also. As an OBGYN, we should be well versed with the POXO Act, and I know by now we all are very much aware of the PCP and DP Act. And mob violence, yes, we are asking for the protection of doctors, violence against doctors, but still lot needs to be done. And TNFOG, under this platform, by having this topic, you are again sensitizing our members. You are making them aware what they should do when you encounter with such a situation. And your reverse panel, that is with practical aspects, will be, I am sure, it will really enrich each and every delegate. I can see many familiar faces, but some faces are unfamiliar. But I'm very happy to connect with all the members of TNFOG, and it's a pleasure to be here on this platform. Ramani, Sampath, and all the office bearers, wish you all the very best for the success of this webinar. And thank you so much for making me a part of this Marathon CME by TNFOG. Thank you.
Thank you, Dr. Lakshmi, for your kind words. And we are again happy to say that apart from our annual TNFOG conference, we have started conducting this mid-year conference, which was held at Tiruvannamalai, a small society which came forward to conduct this mid-year conference that was held on last Sunday. And it was a very grand success with so many participants. And the topics, scientific topics, were all very well chosen, and thanks to Dr. Radha Madhavi and the team for organizing such a wonderful mid-year conference. I think every society of Tamil that comes under the Tamil Nadu Federation of OBGYN, they are also conducting a TNFOG session during their annual CMV, and the same thing it was held at Dindigul. And subsequently, in the coming months, whichever society is doing the annual CMV, they will be doing this TNFOG session. So that is really a great honor to TNFOG, and that's a way that it can spread its wings across Tamil Nadu and reach all the members. Thank you.
Great.
Ramani madam, one thing about Lakshmi madam. If any topic who cannot talk means, we can give the topic to Lakshmi madam. She's deliver the topic. Thank you, Lakshmi madam, for your occasion, for honoring our invite. Thank you. Thank you, madam.
Thank you.
Dr. Gayatri, we'll go with the Yuva session. Lakshmi madam, if time permits, you can enjoy the session.
Yes, I'm here.
Okay. Thank you.
Thank you very much for starting the program with a great zeal and enthusiasm. With this, we'll go to the first session, which is the Yuva session. Dr. Sampath Kumari has already elaborated the purpose of the Yuva session, and this will be strictly timed. For being the judges, I call upon Dr. E. Shanti, who is a professor of Obstetrics and Gynecology Department in Savita Medical College, Chennai. She is an alumni of the MMC, prestigious MMC, and she's also trained in ultrasound, advanced infertility, advanced laparoscopy, and she's also a provider and an instructor course also she is trained in. She has more than 25 publications to her credit. Her field of interest include endoscopy, high-risk pregnancy, and adolescent gynecology. And she has a lot of achievements to her credit. She's been an invited faculty in a lot of conferences and organized national and international conferences. She's also an examiner for the UG and PG, so an apt person to be the judge for today's Yuva session. Along with her, we have Dr. Kartika Prabhu, who is a professor in SRM Medical College, Potheri, Chennai. She did her MBBS in MMC and her MD in JIPMER. She's also a teacher for both the undergraduates and postgraduates with special interest in high-risk pregnancies, gynec endoscopy, and midlife health and healthcare. She has a lot of awards to her credit. She's a winner of AV Umachiu Memorial Gold Medal, Asha Bakshi Award, A.L. Mudiraya Traveling Fellowship. She has more than 20 national and international publications in her name. She's also been a faculty in the national and regional conferences. Over to the judges to introduce your Yuvas and take over the session.
So I invite Dr. Vanati Sindhal, who's a consultant of Thangam Hospital, Dharmapuri, to present the first topic. She did her MBBS from Tanjavur Medical College, MS from Mahatma Gandhi Medical College, Pondicherry, and she has done fellowship in minimal access surgery and diploma in minimal access surgery. She has presented various papers and posters and has got Best Paper Presentation Award in Foxy Presidential Conference. She is a present consultant in Tangam Hospital. She will be talking on examination of rape victim.
Good evening, everyone.
Three minutes, judges will ask the question, 12 minutes for presentation. You can start.
Ma'am, my presentation is seen completely, ma'am.
No, ma'am, it's in normal mode. Can you make it as a slideshow mode?
Slideshow, please.
Is it fine, ma'am? No?
Yeah.
Yes, ma'am.
Good evening, everyone. Today, I'm going to talk about examination of a sexual assault survivor. WHO defines sexual offense as any form of sexual violence in any environment perpetrated by anyone to the victim using a threat or a force. In 2013, Criminal Law Amendment Act redefined the definition of rape as all forms of sexual violence penetrative either by oral, anal, or vaginal, by either penis or the object or the weapon or the fingers, and non-penetrative assault such as touching, fondling, or stalking. Everything is included in the definition of rape. The Ministry of Health and Family Welfare gives two unique terms, victim and survivor. Who are victims? The victim, the term literally means a person who is suffering from the harm, including non-consensual sexual violence. They endure physical and emotional harm, and they require compassion, validation, and support. Hence, we do not use the term victim in the whole guideline. And on the other hand, they give the term survivor, which the term itself acknowledges the individual's strength, resilience, and emphasizing that despite being victimized, humiliated, and traumatized, the person retains the capacity to make decisions and take control of her life. This language fosters empowerment and validation. Hence, in the whole presentation and also in the guideline, the term survivor is used. The guideline emphasizes the right to health care, to provide accessible, non-discriminatory, quality, physical and mental health services to the survivors. All the procedures must respect the survivors' privacy, dignity, and autonomy. A practitioner who is refusing the care to survivors of the sexual violence is a punishable offense under Indian law. So what are the roles of health professionals? We play dual role. First one is to provide medical treatment and psychological support. The second one is to assist the survivors in their medical legal proceedings by collecting evidence and ensuring a good quality documentation. So when the survivor comes to us, what are we supposed to do? This chart briefly tells us what are we going to do. After obtaining the consent, we are going to give the first aid, followed by a detailed history collection and thorough examination of the survivor and evidence collection. With that, we are documenting and packing all the evidences and handing over to the police. At the same time, we should treat the survivor in terms of the prophylaxis and emergency contraception. So how do the survivor come to us? They can come by three ways. Either they will come on their own, only for the treatment of effects of assault. They do not want any police complaint or whatever. Second one, with the police requisition, after the police complaint, the police will bring the patient to us, or with a court directive, they will reach us. Who can conduct the examination? Under section 164A of Criminal Procedure Code, a registered medical practitioner in a hospital run by either government or a local authority can conduct this examination. Possibly, preferably, a female examiner is allowed. If a female examiner is not there, we should not wait for them to come. Any RMP should start the examination. And whatever the approach, the 3 ways the survivor can come to us, our duty is to make the medical legal case report. Any survivor has the right to give the consent or refuse the treatment and the further examinations. So we should respect their decision. They should give their informed consent for examination for treatment and also for medical legal examination and evidence collection. If the survivor doesn't want it, we should respect their refusal. Only in the life-threatening situation, the doctor can initiate the treatment without consent as per section 92 of IPC. While the survivor is giving the consent, it should be signed by themselves if they are above 12 years of age. Consent must be taken from the guardian or the parent if the survivor is under 12 years of age. After getting the consent, we are going to collect the basic information such as name, address, age and sex of the survivor, date and time of receiving the patient, name of the person who brought the survivor and relationship to the accompanying persons. Followed by size, shape of the 2 identity marks. Menstrual history is important because some amount of evidence might be lost because of menstruation at the time of assault or the examination. Vaccination history is equally important. The most crucial critical history is sexual violence history. While taking this history, we should be very sensitive and acknowledge the survivor's strength for seeking help. We should not be judgmental and we should create a safe and private space for the survivor to speak about. And our Ministry of Health and Family Welfare has given a detailed pro forma, which will be useful for the doctors to follow. I have attached a few of the screenshots of the guideline. So date of the incident, time of the incident, and location should be reported properly. The duration between the assault and the examination should be detailedly recorded. Name, number of the assailant and sex of the assailant should be reported. If the survivor has endured any physical violence, it should be reported in detail. Regarding the penetration, if it has occurred either by penis or any other part of the body part of the assailant or by fingers or by object into the vaginal orifice or anal orifice or the mouth, anything should be detailedly, we should report it. And about the exhibitionism and masturbation, we should write the Y, N and DNK reports for yes, no and do not know. This should be clearly asked to the survivor and they should be able to answer to you. And if ejaculation has happened, whether it is inside the orifice or in the outside orifice area. Other than non-penetrative assault like kissing, licking, sucking any part of the body, touching, fondling should be reported. And usage of condom is very, very important because if condom was used, we might lack the evidence of seminal fluid and spermatozoa. So it should be recorded. Most important is again, after the incident, the survivor has changed the clothes or undergarments. She has cleaned or washed her clothes or undergarments, bathed, douched or passed urine and stools, because this also hinder the evidence quality. After the detailed history, we are going for medical legal examination. What are the prerequisites? We should have a separate room for the privacy of the survivor and safe kit. Safe kit is sexual offense forensic evidence kit, which includes pro forma for evidence collection, envelopes with labeling, many swabs, backwardness for blood samples, comb, scissors, and many other forms. Protocol from Ministry of Health and Family Welfare we should have, because in that only we are going to record all the details, and police intimation. Initially, general physical examination will be done, such as pulse, BP, temperature, and other details. And patient's orientation is important, and signs of any intoxication is present or not, we should record it. Before examination, before the general body examination and local examination, the survivor is asked to stand on a widespread white paper, and we will ask her to undress herself. The doctor should not attempt to undress. First the outer clothing, followed by the inner garments. Anything that falls on the white paper, it should be collected. These are the debris for evidence collection. The clothes should be examined for blood, semen, mud and saliva. Inner clothes should be collected separately. If stains are there, while packing, the paper should be placed between the stains. Coming to the examination of injuries. Only in 1/3 of the cases of forced sexual intercourse, we are going to have injuries. In that cases, we will be recording any bruise, nail abrasion, teeth bite mark, cut, laceration or tenderness. And regarding the size, shape and color of the wound, we will be noting. Each and individual body part should be noted. The details are given in our guideline. All the injuries are noted on the body charts with the numbers. Local examination of genital parts. External genitalia and perineum are observed for injury, seminal stains, and pubic hair. Pubic hair is examined for any seminal deposits or stray hair.
டிஸ்சார்ஜ் நம்ம எழுதி கேஷ் இட்டு ஒரு 3 நாள் கொடுக்க சொல்லி இது உள்ள கொடுத்துட்டோம். அப்புறம் எனக்கு நேத்துக்கு வாங்கினது கேக்கும் ஒரு பாண்ட்.
Vulva and vagina will be inspected for injuries like bleeding, tear.
அதே மாதிரி இதுவும் ஃபில் பண்ணணும்.
Speculum examination we do not do. For adult females, for examination purpose we might do. For children and young adults, it's better to avoid speculum examination. Micro injuries, often invisible, can be highlighted with 1% toluene in blue as shown in the figure. For vaginal examination is not indicated in a medical legal case. It should be avoided. And status of hymen is also irrelevant because it might tear due to other reasons unrelated to sexual violence. Only if any fresh bleeding or tear is present, we should document it. Anal orifice and oral cavity to be recorded for bleeding, swelling, tear, discharge, or any other injuries. Again, all the genital injuries are marked on the diagram with the body parts given in the guideline. After the detailed history and examination, we are going to the main part, which is the collection of sample for hospital laboratory. Basic blood collection for HIV, VDR, and HPCG should be done, and urine pregnancy test should be performed. If it is the police requests any age estimation, we should be able to do radiograph of the wrist, elbow, shoulder, and dental examination. For suspected fractures, we should do X-ray examination. Collection of samples for forensic science laboratory. With this, we divide into 4 parts. Debris collection paper, as we discussed before the examination, patient will undress and we will be having the debris collection paper. Second one is clothing evidence. If it is available, we would be doing it. Third one is body evidence sample, and fourth one is genital and anal evidence. Body evidence samples are these swab we should take from the stains on the body, either from blood, semen, or foreign material. Scalp hair, we should take it. Head should be combed, the hair should be combed, and the stray hair will be collected. Nail scrapings and clippings are important because the DNA of the epithelial tissues might be present. The evidence will be useful. Oral swab, if the history of oral sex was there. Blood for grouping testings and alcohol intoxication is important. And blood for DNA analysis. Urine for drug testing. Any other material, lubricants, condom, object was there, we should take the specimens. Genital and anal evidence, we will be taking the mated pubic hair, and pubic hair will be combed as I said previously, and cutting of the pubic hair. 2 vulval swabs will be taking, 2 vaginal swabs, and 2 anal swabs if there is history of anal sex. If any swab, when we are taking, it should be dipped in a distilled water before we take the swab. And urethral swab and swab from glands of penis or clitoral penis in case of other sex. All the evidence should be labeled properly, packed, and sealed before we send to the investigating officer. And chain of custody should be maintained. That is very, very important in the form of safe providing the evidence. After the detailed history and examination, we will be providing provisional clinical opinion in this form. So rape and sexual assault are legal terms. We will not use it. So doctors can do only medical examinations, and we can give whether the forceful sexual penetration has happened or not. So these are the formats given in our guideline. If genital and physical injuries are there, the signs of recent use of forceful penetration of vagina or anus or was there or not, we will be telling it. So these details are given elaborately.
Dr. Vanati Sendil, your 12 minutes is up.
Okay, I finished it, ma'am. Thank you. So after the forensic science laboratory report, we will be giving the final report. All the final opinion, Ministry of Health and Family Welfare has given a detailed pro forma. We can just see and do whatever is needed for our patient. And treatment, as I said earlier, this is the last part. Injection TT if they are not immunized previously. STD infections, if there are signs, we'll be treating it. Hepatitis B, immunoglobulin should be given if previously she was not vaccinated. An emergency contraception if the patient comes within 3 days. After the examination, we are handing over the report, documenting it properly, formulating the opinion, signing it, and then handing over to the investigating officer. So at this point, since the topic is medical legal case, I cannot end my presentation without mentioning Abhaya case. As everyone is waiting for justice, no other case other than this case right now will emphasize the importance of the proper medical examination and evidence collection. As doctors, we might not be able to arrest or find the perpetrator, but all we can do is give proper medical examination and evidence for the administration to find the perpetrators. Thank you so much.
Thank you, Dr. Vanati, for our very elaborate and full-length description of examination of a sex victim. So you have covered everything completely. So can you tell within how long you should do the examination of a sexually assault victim?
Whenever the survivor comes, we are going to do examination, madam. But for the evidence collection, like the clothes, the recent seminal swabs, if the perpetrator, the survivor comes within 3 days or maximum 4 days, we are going to collect all the evidence. Otherwise, what are the relevant evidence we will be collecting? Any time of the year, any time of the time, if the survivor comes, we are bound to examine the survivor.
Yes, but for evidence collection, it should be as early as possible.
And can you comment on that 2-finger test that is usually,
Yes, ma'am.
that 2-finger test?
2-finger test is a term for pervaginal examinations, which is performed by us.
Yes.
For any sexual assault case, for a rape, to confirm rape or to confirm sexual assault, pervaginal test is not needed. Our guideline says do not do pervaginal examination. So we are not doing it.
It is not that it is, you should not do. If it is medically indicated, we can do. But when the vagina, you need not comment about the size of the introitus. So 2-finger test is that if it allows, if 2 fingers, that means sexual intercourse has occurred. But that doesn't mean that has occurred recently. Okay. So that is why it has been banned nowadays. We don't use the term. And even speculum examination, if it is indicated, it can be performed, and it should be performed when you suspect any penetrative intercourse. And especially in young girls, if it has to be done when you anticipate any bleeding or some discharge, it can be done under general anesthesia. It is not like you should not do. If it is indicated, you may have to perform certain times to collect the evidence like swab test or something like that. When you do it on a minor, to be done under anesthesia. Okay. And how do you follow up these cases? Like when do you ask her to review?
If the patient was menstruating or the assault has happened recently, we will ask her to come after 2 or 3 days so that at that time bruises will erupt. It will be easier to comment on the injuries.
Okay. Then?
And if she has any STD infections, if we are giving the treatment, we will be asking her to come back after a few times. And VDR, she should be coming back after 6 months or 1 year for testing and diagnosis.
What is mentioned is about 3 days and then 3 weeks and at the end of 6 weeks. So they have to be called back to for review. Because we need to check whether though UPT may be negative at that point of time in the initial visit, we need to repeat it after they come back, right? And we should do other tests, relevant tests if it is needed. Thank you. It was a wonderful presentation.
Thank you.
Shanti, you can invite the second speaker.
Yes. So it gives me immense pleasure to invite Dr. S. G. Vijayashree, who is the assistant professor from the Coimbatore Medical College. She has done her MBBS in Tirunelveli Medical College, her MS at Coimbatore Medical College. And she is a UG, PG teacher for the past 6 years. She has many publications in the international journals, and her special interests are in social obstetrics and infertility. Dr. Vijayashree, please.
Thank you, ma'am. Thank you for the kind introduction, ma'am. Visible, ma'am? Screen visible?
Yes, ma'am.
Yes, you can start. Your time starts now.
Thank you. So my topic is about today is about NTP Act, POCSO Act, and PCPNDT Act. Now coming on to smart introduction about abortion, Ministry of Health and Family Welfare 2018 guideline states that nearly 56% of 6.4 million abortions which is occurring in India are unsafe, and it accounts for 8% of maternal deaths, and 1 in 12 deaths are due to abortions, and 10 women die due to unsafe abortion each day. And coming on to the history of MTP over the last 50 years, before 1971, IPC criminalizes abortion, and by 1971, Medical Termination of Pregnancy Act came into existence. And after 30 years, in 2002, the amendment of MTP Act, where a registered medical practitioner can provide MTP in approved site, which is being approved by the district level committees. And after that, last amendment, MTP Amendment Act, came into force in February 2020. Medical Termination Pregnancy Act, the main amendment came in 2002, which decentralizes the process of approval of private places to offer abortion services, which can be approved by the district committee in order to increase the number of providers. Salient features of MTP Act and MTP rules and MTP regulations has been formulated. In the MTP Act, the conditions under which the termination can be done includes therapeutic, eugenic, humanitarian, and social grounds. And pregnancy can be terminated in either a government hospital or a district level committee can approve a private provider to do termination of pregnancy. Who can terminate pregnancy? It includes registered medical practitioner who is registered in a state medical register and who is a PG degree holder, or who has done his house surgeonship 6 months in OBG, or who has worked for 1 year in any OBG which has been doing abortion services, or even a registered medical practitioner who has assisted in 25 cases of abortion, but he should have done at least 5 abortions on his own independently. And the main documentation in MTP Act includes the Form B, which is the approval certificate. Form 1 is the opinion form. Form 2 is the monthly reporting format. Form 3 is the admission register. Form C is the consent form. So coming on to Form B, it is a certificate of approval. All private centers should display this Form B, and government centers by default is approved and they do not need the display of this certificate. And this certificate does not require renewal. Both private and public facilities should have signages indicating availability of the abortion services in their center. And Form 1 is the documentation. That is, opinion form with reason for termination should be entered within 3 hours of prescribing the pills. And in case of second trimester abortion, the second registered medical practitioner's consent should also be obtained. Whereas incomplete abortion, inevitable abortion, missed abortion, blighted ovum, or obstetric complications, and they do not come under the MTP Act. Form 2 is the monthly reporting format. It includes both medical and surgical methods should be involved. And Form 3 is the admission register. It is a very confidential register. No entry should be made in a case sheet or OT register. Entry should be made only in the admission register, and it should be maintained for at least 5 years. Form C is the consent form. Consent, the only consent of the woman is required if the age of the patient is less than 18 years, or in case of mentally ill patients, the consent of the guardian can be obtained. Additional record of age proof is not needed. These are the forms which should be consent form and the opinion form. Then confidentiality of the records should be maintained in any case of abortion, which includes the consent form, certified opinion form, envelope to CMO, which should include the serial number from the admission register, and the name of the registered medical practitioner should be mentioned. This is done to prevent unsafe abortions as they may occur due to social taboos. And any violation of this can result in rigorous imprisonment ranging from 2 to 7 years. MTP Amendment Bill, which has been passed in February 14, 2020, it includes the major changes that, such as only one registered medical practitioner approval is required up to 20 weeks of abortion, and 2 medical practitioners approval from 20 to 24 weeks. And in case of fetal anomaly, there is no limit of gestational age. And if the termination is done more than 24 weeks, then medical board approval is required. So this in fact tells us the difference between the old and the new Amendment Act 2021. Comparing both these things, initially, in case of contraceptive failure, previously it was applied only for married women, whereas in Amendment Act, even unmarried women are also covered. And the limit of gestation is 20 weeks for all indications, whereas it is 24 weeks for rape survivors and beyond 24 weeks for any substantial fetal abnormalities. Opinion of the doctor is 1 registered medical practitioner till 12 weeks and 2 registered medical practitioner till 20 weeks. Whereas in Amendment Act, 1 registered medical practitioner till 20 weeks and 2 medical registered practitioner till 20 to 24 weeks. Medical board approval is required if abortion is planned after 24 weeks. Fetal abnormalities. In case of fetal abnormalities, initially it was 20 weeks is the limit on gestation, whereas in Amendment Act, there is no limit for gestational age. If there is any breach of women's confidentiality, fine of up to 1,000 was enacted, whereas in Amendment Act, fine as well as imprisonment for 1 year is also given. Now, coming on to protection of child from sexual offences, which is the POCSO Act, the government of India has brought in a special law, namely protection of children from sexual offences, which has come into effect from 14th November to deal with child sexual abuse cases. So, who is a child? So, child is a person who has not completed 18 years of age. So, it is a law that came into enforcement in 2012. POCSO protects children. It includes both boys and girls below 18 years of age from sexual offences that covers a range of sexual activities such as sexual assault or sexual harassment, penetrative and non-penetrative offences, or pornography. So POCSO Act, it makes it mandatory for a doctor or any other healthcare professional to report the sexual offences against children. So failing to record all these offences shall be punishable. According to Rule 5 of POCSO Act, it states that emergency medical care is to be provided by any medical facility, which may be either private or public. Sexual assault in a child is therefore treated as a medical emergency. So it is a mandatory reporting. So failure to do this would result in imprisonment even up to 6 months. Special courts has been established under the POCSO Act, which is mainly established for handling cases related to child sexual offences. And through the legal process, all the procedures will be child-friendly. The well-being of the child is the priority. And even in recording statement, the child statement is taken when they feel comfortable, and the child statement is recorded exactly as spoken by the child. Child identity protection by Section 23. Media cannot reveal the child's identity without court's permission, and breaching this may result in 6 months to 1 year imprisonment. And speedy trial measures has been given under Section 35, where child's evidence is recorded within 30 days, and special courts aims to complete the trial within 1 year. Role of the doctor is the treatment of injuries and to look for screen for HIV and treat STDs, and emergency contraception should be provided if needed, and counseling regarding the mental health should be taken care of. We should never do two-finger test, and during examination, absence of injuries does not imply assault has not happened. We should also verify whether alcohol or drug is administered to the child, and age can be ascertained by using x-rays. Reporting. So after reporting to police, it will be communicated to Child Welfare Committee within 24 hours. And medical practitioners are not obligated to file an FIR or conduct any investigations. Our duty is to only inform the authorities and to provide services to minor, including abortion services under the existing provision of MTP Act. Legal proceedings, if any, can continue simultaneously, and it should not be a hindrance in the provision of services. And POCSO on marriage less than 18 years, it criminalizes consensual intercourse below the age of 18. So marriage and pregnancy below 18 years is considered as an offense even if it is with consent. Situations that we may encounter is that victim may not want to give police complaint but requires medical examination and treatment. In such cases, the doctor is bound to inform the police as per law, and if the victim doesn't want to pursue a police case, MLC has to be made and informed refusals can be documented. Coming on, and Ministry of Women and Child Development, the Government of India has established one-stop centers to provide support and assistance to the victims of gender violence. Comprehensive services include medical, police, psychological counseling, legal aids, shelter, referral facilities are provided under one roof, which is termed as one-stop centers. Now, coming on to the third act, which is PCPNDT Act. The objective of this act is that the main objective is to stop fetal feticide and to arrest the declining sex ratio in India. This act also regulates the misuse of prenatal diagnostic techniques for sex-selective abortions. This act mandates compulsory registration of all diagnostic laboratories, all genetic counseling centers, genetic laboratories, genetic clinics, and ultrasound clinics. Main provisions of this act includes prohibition of sex selection before or after conception. It regulates the use of prenatal diagnostic techniques like ultrasound and amniocentesis, and no laboratories or clinic will conduct any test, including ultrasound, for the purpose of determining sex of the fetus, and no person should indulge who's indulged in conducting the procedure will communicate the sex to the pregnant woman or to her relatives by words, signs, or any other signals. Each ultrasound clinic, genetic counseling centers, genetic laboratories have to maintain all records on day-to-day basis as prescribed under this law. Punishments and penalty for breaking PCPNDT Act includes the following. For the doctor, if it is for the first time, it's imprisonment for 3 years and fine of 10,000. And the name will be removed temporarily for 2 years from the State Medical Council. And if it is for subsequent penalty will be 50,000 and imprisonment for 5 years, and the name will be permanently removed from the State Council. And in case of parents or relatives, if it is for the first time, imprisonment for 3 years and fine of 10,000, and subsequently it is 5 years imprisonment and 1 lakh fine. Mediator is also punished. Advertisement of sex PCPNDT will result in imprisonment of 3 years and fine of 10,000. A non-bailable warrant is issued and the punishment is non-compoundable. So the do's according to this act is registration of clinic is mandatory. Details of all the machines and all radiologists with the copies of certificate should be submitted, and signage boards in English and local language must be displayed indicating fetal sex is not disclosed in the clinic. Form F must be duly filled as soon as USG is done, and Form G is only for invasive procedure. A monthly report should be submitted before 5th of every month.
Sorry to interrupt, Dr. Vijayashree, your time is up, 12 minutes.
It's not, that's like. Do not disclose the sex of the fetus to anyone under any pressure or in any circumstances, and do not start a USG clinic without PCPNDT Act registration, and do not visit any clinic or hospital unless it is registered for PCPNDT Act. Thank you, ma'am. I thank Tnfog for giving this opportunity. Thank you.
Over to the judges.
Yeah, it was a wonderful presentation. We have almost covered all the topics. And regarding the MTP Act, okay, MTP. So we have a lot of practitioners who run private clinics, right? Only clinics.
Yes,
so can they offer MTP services like services?
Yes,
like medical,
any registered medical practitioners can offer services till 20 weeks gestation, and if in case of any anomalies,
they run only clinics, right? We have OP clinics.
Yes, ma'am.
Right?
MMA kit can be provided by registered medical practitioners, and in case of any emergencies, everyone can offer abortion services, but it should be communicated within 1 day to the CMOs, ma'am.
So
Authorities.
Actually speaking, these practitioners should have what agreement or attached. They should be attached to some of the clinics, which is clinics or no, sorry, hospitals which have the provision for they have got the approval, right, for performing the surgeries. Like, okay, offering. So only then they can. Otherwise, just an OP medical practitioner cannot give that. They should be attached to some clinic which have obtained the approval for center. Yeah, it should be approved. Then regarding POCSO Act, so your presentation was using the term victim. So we don't use the term nowadays. Yeah. Okay. So you could have avoided that. We use survivor, right? Okay. Okay, that's it. And what do you mean by aggravated sexual assault?
Aggravated sexual assault is that if the assault has been committed by a person who is of trust to the child. For example, if it has been any sexual offenses has been committed by a person who should have protected the child. For example, security persons, police, or any public servants. If the offenses has been committed by such person, then the offense is called as aggravated offense.
And the punishment also is different. It's a bit more
Severe. Yes, ma'am.
Yeah. And when it comes to MTP, like how about the discharge summary? Is there anything specific to be mentioned? So you give a discharge summary to them. So
Yes,
how
ma'am.
it should be.
Discharge summary, we should mention the mode of abortion, and sex of the fetus is not mentioned anywhere, and we should ask them for contraceptive advices should be given for these individuals.
Name should not be mentioned in the thing. We should write the serial number,
Only serial
which we
number
use
from
it for the so
admission
nowhere we
register.
write the names, right?
Name.
The same
Yes,
way,
ma'am.
even in discharge summary, we are supposed to mention that number alone.
Okay, ma'am.
Okay, otherwise it was one of the presentation.
How will you give the serial number for MTP?
Ma'am, from the admission register, ma'am, form 3
So
is there. From that admission register,
no, how will you give?
from
There is
there
a
we'll have
format
to
for
see.
that. There is a format for giving the number. So it will be the number followed by the year in which you are taking that.
Okay,
For the entire year, the numbers will be in order. So that number will be followed by the year. That has to be mentioned in the register.
Yeah. Okay.
So can you tell some main prerequisites for examining a child assault patient when compared to that of adult? Prerequisites. You should
Prerequisite,
get
if the
consent
patient,
from
if
the
the adult
parent,
is concerned,
and as well as the parent should be there when you are examining
if the child is less than if the child is less than 12 years, the consent of the parent is taken. The child is more than 12 years, consent of the victim can be obtained. Along with the examination should be done in the presence of the person whom the child trusts, ma'am. It may be a parent or anyone whom the child trusts. And the court official should not be present at the site of examination. They should not be.
It was a wonderful presentation. Yeah, you have covered with Dr. Jishri, you have covered all the 3 topics in detail. Thank you for.
Thank you.
Gayatri, thank you very much.
Yes. Wonderful. Thank you, judges and the speaker.
With this, we come to the end of the UA session. And we'd now like to move on to the next session, which is the scientific session. How do we handle, or what are the updates in how to handle a mob in a labor ward situation? To chair this session, we have Dr. Ramani Devi, who is the president of TNFOG. Over to you,
Gayatri,
madam.
already introduction has been
Pada,
done.
ma'am, over to you, ma'am. Please introduce
Yeah.
our expert and we can start the talk, ma'am.
Okay. Again, I am very happy to introduce Dr. Jitendra Sharma, who's practicing gynecologist and obstetrician in Ahmedabad for more than 32 years. And he is also a medical legal counselor, done his LLB with a lot of gold medals. I think almost all the gold medals that are available, it has been backed by him. And he has authored some of the books especially for law in OBGYN practice, concerns, and laws a doctor must do. He has given more than 1,700 lectures, 10 orations, and he was the vice president of FOXI in 22-23, chairpersons of Ethics and Medical Legal Committee, president of AOGS, and hosted AICOG in 2017 Jan, and joint secretary of SOGOG in 2017-19, and medical legal consultant for more than 225 hospitals all over the world. So I think nobody else other than Dr. Jitendra Sharma can handle this topic of mob attack in the labor room setting. Over to Dr. Jitendra.
Thank you, madam.
Namaste, sir.
Yeah, namaste, madam. Thanks for kind introduction, Dr. Ramani, madam. At the outset, I would like to thank Ramani, madam, Sampath Kumari, madam, and Saravan Kumar, sir, for giving me this opportunity to be the part of this marathon, that is Tnfog Marathon Cme. So, will you like to see the PPT or without PPT?
With PPT, sir, it will be easier for people to follow.
Okay. So let me share my PPT.
Ramani madam, Jitendra sir has reduced more than 15 to 20 kgs.
Madam, 28 kgs.
28.
Very good, sir. I think we should, everybody should know the secret behind that weight reduction.
So we'll have a full CME on it, sir.
Yes, we can.
Obesity.
And it will have the maximum attendance, I'm sure of it.
So my slide is visible now?
Yes, sir.
Slideshow.
Slideshow, put it in the slideshow.
Yeah.
The top, sir, next to animation. Down, here. Jitendra sir, in the top it is there, next to, in between animation and review.
Animation and
review. Yes.
Okay. So, I'm in slideshow.
No, sir, not yet.
On my screen it is showing slideshow.
No, you press the current slide. Slideshow once again. No.
Yeah, reshare it, sir.
Go to slideshow, sir.
I mean, on my computer it is showing full screen.
Okay.
So while sharing the screen, you need to click on the screen tab, sir, so that it will be shared. Yes, sir. Now
it is okay.
Thank you, sir.
So now it is moving.
Yeah.
Yes.
Okay. So thank you, madam, for keeping faith in me that I can do justice to the topic. The topic is mob in labor room. So let us understand what is the meaning of mob. See, mob, the word used is for mobile entity. So a large crowd of people that may become violent or cause trouble, that is known as mob. So a large and disorderly crowd of people is known as mob. And let us understand the meaning of the word violence. What is violence? Violence means anything. See, telephonic threat even is also considered as violence. Intimidation, oral abuses, physical manhandling causing injury or death, or damage to property. These are all the different kinds of violences. See, are we discussing something which is not required to be discussed? It is not so, because the incidences of mob violence are on rise. Every day, we are getting some news on WhatsApp from some corner of India that there is a violence against doctor. Not only India, but it also prevails in US, UK, China, and all other countries. Why do our client become aggressive against us? Why is this trend increasing? I am not going into much detail of that today because that is not the topic of today's lecture. But lecture is on how to handle. But at least we should know what are the reasons. Low healthcare literacy. We talk only about the success. So people don't accept the complications. They are not ready to accept complication from the doctor. We only talks about our success and not the failures. Even media people only talk about the success. The failure is not been printed anywhere. So people usually talk ill about us. Whenever people speak something about doctor nowadays, they say, are you a doctor or butcher? Doctors are making money by looting us. Doctors are making money by taking commissions. Doctors are taking favor from pharma company for tours and travels. Parents had too much money, so took admission in medicine. Actually, they don't know anything. Doctor is of reservation quota. So there are multiple things which people used to tell about doctors. And political parties also treat us as a soft target. Even the literate are instigated to be intolerant and generally unhappy with the doctors. Alcoholic and drug addicts add fuel to the fire. So these are all the reasons why people are now expecting much from the doctor, and mob very quickly gathers whenever there is any untoward incident in the hospital, because the society has become more demanding, more availability of knowledge from different Bhagwans like Google Bhagwan. So everybody knows what is going on. More aggression in the society and more violence on road, public places and other places. So the main reason of all these things that we are poor in communication. The reason is that senior doctor had no time to speak with the patient directly. Junior doctors who speak, they could not explain very well. They are made to wait. People are made to wait for a long time to meet the doctor. And sometimes doctors are not empathetic to the patient. So these are all the reasons of gathering mob. So we are definitely in a vulnerable stage. We all know whenever we discuss about medical legal subject, I always start my lecture saying that ignorance of law is no excuse. So we must know different laws applicable or different laws which gives right to us for our own protection, and prevention is always better than cure. So we should take preventive step rather than curative step. How can you prevent these mob violences and other things? By effective communication, we can definitely prevent this violence. Not giving false assurances. We should not give false assurances to the patient. Keeping your behavior modest. Explaining complication which had occurred in detail to the relatives. Not hiding anything. You should be genuine and honest towards your patient and towards their relatives. Giving all the papers related to treatment. You should not restrict yourself in giving papers so that the patient relatives can get confidence. Allowing patient to take second opinion. Involving other colleagues in the treatment whenever need arises. You should remain clear in your bills. So financial counseling should be done in advance. You must develop sense of detecting the litigant in advance. You should know that which is the patient who is going to create problem for you medico-legally. And last but not least, escaping from the place before it's too late. So if you feel that they are going to harm you bodily, then you must have a place to escape in your hospital. We all know how mob gathers. See, whenever any incidents happen, first the distant relatives come, then neighbors gather, then some dissatisfied client also gather with them, and last but not least, local leaders and their vote banks gather slowly. So slowly mob gathers. And what is the thing which happens? See, whenever anything happen, when doctor starts speaking with the relative, the first person who comes to the doctor, he explains that everything in detail, that I was doing this and this happened, I tried this, I tried that. So multiple things doctor explain, and then immediately after that some other relatives come, then again once again doctor narrates everything in detail, and one by one relatives come, and one by one doctor starts narrating. And when the fourth relative come, doctor explains in brief only that, see, I was doing cesarean section and there was bleeding. I tried my level best, but ultimately patient died. But no details are given. And that fourth relative is always the close relative or the husband of the patient. So, dear friends, how to protect doctors and hospital from these type of aggression? So, there are a few things which we should keep in our mind. First, doctors should not have fear in mind. Doctors should not become aggressive against the mob. You should keep your calm. That is the first principle in dealing the mob. That stay your calm, and calmly you have to explain to the relatives and to the people who are available. Communication is the key to prevent mob reaction. So whenever you tackle the mob, see, there is a mob. You have to detect a few people from the mob who can understand you. So prominent looking person or leader-like looking person should be selected, and a few near relatives should be asked to come into your consulting room. And you should not do any casual talk with the relatives. Sit in your consulting calmly, and there is a method known as spike method. You should sit calmly, you should explain everything in detail, you should allow the patient to ask questions, allow the relatives of the patient to ask question, you should give them detailed information, you should allow them to interact, and you should be empathetic with them while explaining. So follow the spike method, and the mob violence can be avoided. In all the areas all over India, there is a system that we should have a rush team in our area. So in every city, even Indian Medical Association also and Foxy also suggested that every city should have rush team. You can have a mob, this WhatsApp app where or WhatsApp group in your area. So in that group, you can send the message, single message, and that message will reach to all your colleagues through that group, and everybody can be easily gathered as early as possible. Recently, multiple incidences of mob violence we could avoid in Ahmedabad because we have developed one WhatsApp app where whenever there is apprehension to any doctor that manhandling or damage to property will occur or mob will gather, then they usually call their colleague on WhatsApp, and immediately 50 to 20 doctors who have time reaches the place. And when we create mob of doctors against mob of patient or the relatives, then we can definitely protect them to become violent. So we can avoid these kind of incidences by making rush team or by making WhatsApp group in our hospital or in our city. See, phone a friend is the alternative. We can call nearest friends whenever need arises or mob gathers. Always call police first, because what is the first thing we should do whenever we suspect the violence? Then we must call police. We can call on 100, or we can call if we have any other numbers of the police station. So the reason why we should call, because if you call police, police will most likely protect you. But if the police is called by the patient's relative, then police will try to protect them rather than you. So benefit of calling police, that mob and other patient will feel that you are genuine, and hence you do not have fear of police and you called police. Extreme violence and damage to the premises can be avoided by calling police. And last but not least, if patient is dead, then getting post-mortem will be an easy job, because only police has to be the body is to be handed over to the police for the post-mortem. So how to deal with police? So there are certain do's and don'ts in regard to dealing with the police. Explain them things in short. Ask them to provide you and your premises protection. Answer their questions calmly, and if they ask for case record, give them summary of the case by writing it in a paper. Don't give case paper if it is not complete. But even if they insist, you can write on the case paper that this is an incomplete case paper and hand it over to them. Even if it is complete, then give photocopy, not the original. Put page number and take signature on them of the receipt. Don't say no to sign anywhere. If police asks that you should sign somewhere, you can sign, because signing does not mean that you have accepted. So never argue with the police and never protest, but sign whatever they want. If police asked for case paper from you in emergency, you can give it to them as incomplete, writing on the case paper as incomplete. Never try to bribe them. Never try to hide anything from the police officer. And death certificate only can be issued if you know the cause of death. Otherwise, you should advise for post-mortem. So the principle of advising post-mortem, you should never succumb to the demand of the relatives or the police to give death certificate. Death certificate is a misnomer. It is not the death certificate, is not the certificate of declaration of death, but death certificate is a certificate of cause of death. So you should not issue the death certificate to anybody for any patient unless you are 100% sure regarding the cause of death. And when there is a sudden death in four wall, suppose in labor room or in operation theater, where the relatives have no access, the burden of proof in the court of law to prove the cause of death will be on the head of the doctor. And that's why it is always advisable to advise post-mortem and not to issue death certificate. Mention the name of the miscreants. See, whenever police is being called, if there are miscreants in the mob, then you should give names of those miscreants to the police officer. It is always advisable to give footage of CCTV if it is there in your hospital. So it is advisable to keep CCTV in your hospital, and always insist for FIR if any mob has gathered and they have done something wrong against your body or against your property. This is the kind of notice. This is in Gujarati in Gujarat. You can keep it in Tamil Nadu. And see, we all know that Gujarat, this Medicare Service Person Protection and Medicare Service Institution Prevention of Violence and Damage or Loss of Property Act are there now in 19 different states applicable, and we can take benefit of this, and we can ask police to register a case against the miscreants under this act. Offense under this act is cognizable and non-bailable, so they can definitely be arrested. And there is provision of 3 years imprisonment and fine up to 50,000 rupees in this particular act. Compensation twice the amount of damage can also be asked for under this act. So keep a copy of this act with you and always demand from the police that a case should be filed. There is hue and cry all over India that doctors should be protected, but our political ministers, the Home Minister even once upon a time opposed in Rajya Sabha and Lok Sabha that there is no need for special act for special protection of doctors because they are also human beings and there is no special need to protect them. Although these all sections are from old IPC, now number of these sections have been changed, but all the provisions are there in new Bharatiya Nyaya Sanhita to protect doctor. So already multiple provision under Bharatiya Nyaya Sanhita are there which protects doctor. Install CCTV in hospital. If you will install CCTV, definitely you will be able to record and know that who are the miscreants and what kind of damage to the property has been done by the mob, which you can ask from the indemnity or insurance company. Do we have a legal right to hit back? Answer is yes. See, whenever mob gathers and they enter in the premises of your hospital or labor room or in OT without your permission, that amounts to criminal trespass. And you can apply pressure to throw them out. So the reasonable pressure you can definitely use. And if they cause you any kind of physical injury or grievous hurt, then you can even also have right to kill them. So there are multiple rights with you, which you can use. You can also depute someone else to do the throw them with the force out of your hospital. So definitely you can take help of private security or the bouncers. See, in Mumbai, they have taken services from top line security. So retired security people are there in that, and retired military men, they have a group of people, and whenever there is apprehension and whenever they are being called by our association, they immediately reach to the place with all kind of facilities available with them so that they can protect damage to the doctor physically and damage to the property. So in providing a shield around the doctor and staff, definitely these kind of services can be helpful. We can keep gun. Everybody doctor can keep gun with them for their own protection. Cricket bat, hockey stick, garden stick. These are all different instruments which we can keep in our hospital for our protection. And who other than doctor can use the surgical knife in emergency to protect his life. So whenever there is you have apprehension, and if the mob is causing physical injury to you, then to save your life, you can also use even surgical knife in emergency to safeguard yourself. Dogs can definitely help you. You should always be insured, and your property should always be insured. So insurance of damage to furniture, riot, fire, calamity, these all kind of insurances you should take. And if insurance is taken, then and if you already have insurance, that immediately after the incidents, you should inform the company people, and you should keep CCTV footage with you and take the photograph of the damage done to the property. So this is required by the insurance company to settle your damages. It helps by protecting the hospital from financial losses. So photograph of property should be taken and should be kept in your custody. Insurance agent should be immediately called, and you should write the names of the witnesses who are present over there at the time of incidents, because later on you may forget that who were the people present over there and who can become the witness. So write the names of the witness so that you can remember those names. If any injury is caused to you by any mob, then you must get medical checkup done. So if you are physically tortured or physically affected, or your staff has been physically manhandled, then you should go to the nearby government hospital and get your medical checkup done and take the medical certificate of the injury. It will help you in the future to prove that what kind of physical damage is caused by the miscreants. Preserve the MLC case paper and injury report of the government hospital which has been issued. Last but not least, we must also always keep one door ready for running away. So if you have apprehension that there is a risk to your life, then you must, although it is not considered as cowardice act to save yourself, you must flee away or use that extra door which you have kept to flee away from the place of hospital. Last but not least, whenever anything happens, then we must know that we must file FIR against the mob creant. And we all know that immediately if there is death of the in the hospital of the patient, then police may not take immediate action against the miscreants, but at least they can protect you. And if you file FIR, so after 10 or 15 days, the police may take action according to that FIR under this Protection Act or under different section of Bharatiya Nyaya Samhita. So, dear friends, whenever you file FIR, insist upon police for arrest. Delay in arrest may be caused by the police, but you should put your demand even after 10 days, 13 days, or 1 month. If the action is not taken by police against the miscreant, then you can definitely go to the court of law directly to file an FIR and for taking the action. You may contact the senior police officer. You can ask them questions under RTI that why actions are not being taken. And you can definitely take use of media and do a writ in the court of law for taking action against the miscreant. So, dear friends, the carry-home message is that be master in communication. Install CCTV camera in your hospital. If you are ransacked, then file FIR. Police may not arrest the person because he lost a relative. But after, say, 10 to 15 days, if they don't arrest, then go in RTI or under writ to file a case against the miscreant directly in High Court. Have contract with security services. So, dear friends, although I have finished too fast, a little bit fast, but all these things are known to our dear friends. Only thing that in emergency we should keep calm and make our mind active that how to counter this. It is not the strongest of the species that survives, nor the most intelligent, but the one most responsive to the change. So there is change in the society going on, And we all know that in our society now, the tolerance is getting less and less day by day, and the incidences of mob violences are increasing. So we have to change ourselves. We have to change the system of our practice. We have to communicate properly. Medical counseling, financial counseling should be done to every patient who has been admitted in our hospital in detail, which can definitely avoid these kind of incidences. So, dear friends, good communication is not just necessary to prevent yourself for medical legal problems, but good communication is also a reflection of good human nature. Thank you. Thank you very much.
Thank you, sir, for your excellent talk on this particular topic of mob violence in any labor ward. I think this is a very important topic, and you have explained in detail what are the steps that have to be followed up whenever there is a problem in the labor ward or in the OT. And as you have rightly pointed out, that we have to have a time-to-time communication with the patient. Time to time, you tell them what is happening. If the patient deteriorates, probably you have to explain to them, these are the things we have done. In spite of it, the patient is deteriorating. I have called in for a help of another consultant, but in spite of 2 or 3 consultants trying to save the patient, then we have to put it in such a way that doctors are always there to treat the people, treat the patients and get them back. But it is occasionally we do have failures, and that has to be explained. And then I personally feel that we have to have a local sort of communication with the local police station. Try to get familiar with some of the, at least the SI. So in the case of trouble, immediately call them. So they will be able to try to handle the situation. So these are all some of the things what I wanted to tell you, what I wanted to add. And then thank you so much for sharing your knowledge on this particular topic. And the concept of rush team that exists almost in every city, and I think sending them WhatsApp messages. And you have rightly pointed out, we can hire some this sort of people to protect themselves, protect ourselves during the mob violence. Most important thing is having a good rapport with the neighboring hospitals, neighboring doctors and neighbors. That is the most important thing that can help us out of this sort of problem. Thank you, sir. Thank you very much.
Thank you, madam.
Thank you, Jitendra, sir.
And madam, I will pay my regard to Vivek Madi, sir, who is present today here, and other senior people who are present in this webinar, and will definitely ask for blessings of all Tamil Nadu during my elections, because I am going to contest as a president Foxy this year, 2025.
All the best, sir. All the best.
Thank you.
We will call you in person.
Sure, madam. Thank you. Thank you.
We wish you all the best, sir.
Thank you.
Now it is quiz time for us.
Thank you, sir. Thank you.
So this is the question for session number 2. And delegates, please answer and answer quickly. The fastest answer is going to attract a prize.
Faculties cannot answer, only delegates.
Sahiti, I hope you are at it.
Gayatri, read the question and answer.
Okay.
MCQs.
Which is the one most important thing in avoiding medico-legal suits and mob reactions? Would you give the maximum importance to documentation, communication, the treatment protocols that you follow, or prayer?
This is just to encourage the delegates, sir.
If the time is up, then I'll give the answer.
Documentation.
Shanti, you cannot answer. You are faculty. Shanti இல்ல வேற யாரோன்னு நினைக்கிறவங்க.
நான் மேடம் சந்திரகலா.
சந்திரகலா மேடம், நீங்க கூட faculty தான். You cannot answer. Only delegates. They have to fill up the Google form. அந்த form போட்டிருப்பா. Okay, 1 minute over.
No, ma'am. The form was not sent in the chat box.
Oh, not sent. Then we can send after both the questions
Okay,
combined.
then
You can-
I'll not give the answer now. We'll do it later.
Gayatri, you didn't send to Sahiti?
No, ma'am.
You have to send, then only they will phone. No problem. After the
Okay,
panel,
ma'am,
we
I'll
can
do that.
Okay, no problem. Okay, we'll go to the panel.
Okay, with this, we complete the second session, and the last session is about what are the common medical legal issues that we face in our department, the ONG. Can I have the CV, please? For this, we have with us Dr. Vivek Madi, sir, who is a consultant and director of RK Malati Hospital in Chennai. He's an executive committee member in the World Federation of Medical Education. He's been a faculty in the Department of Education and an international chair in bioethics. He has run his reproductive health law and has been a vice chair there. And he has a lot of textbooks to his credit on bioethics, medical ethics, and health law. We are very happy to have you with us, sir. And this is going to be a reverse panel. So we panelists will be giving you questions and other things. Ma'am, to introduce the panelists, sir, would you like to, sir?
Yeah. Thank you. I like to thank the organizing committee, especially Dr. Sampath Kumari, Dr. Ramani Devi, for asking me to moderate the session. I'd like to introduce Dr. A.R. Shanti, who worked in ESI Hospital and Medical College, and she's been a very vibrant person, especially in medical legal field. She's been interested, and she's been member of government of Tamil Nadu in Social Justice Monitoring Committee, Minimum Wage Committee for Private Hospital Employees, National Secretary of Indian Doctors for Peace and Development, Secretary Doctors Association for Social Equality. Yeah, next please. We have another panelist is Dr. Gayatri, who's done an MBBS, MD, PhD, MLE, and she's a consultant in Shyamla Nursing Home, Trichy. She's from Trichy, and she's an executive member of Trichy Society, and her interests are definitely in the field of medical law, high-risk obstetrics and infertility. Yeah, next please. We have Dr. Geeta D, who's the head of department from the Dindigul Medical College Hospital, and she's also been a recipient of A.L. Mudliar Fellowship Award. She's presented many papers in national conferences, and she's been past secretary of OXY, and she's member of ISAR, member of IAS.
Sir, good evening, sir.
Thank you. Next. We have Dr. Gayatri. She's from medical director of Hari Fertility Center, and she's a consultant in SMS Hospital, Tirunelveli. She has affiliations to different societies, and her special interests are in high-risk pregnancy, infertility, hysteroscopy, preventive obstetrics, and adolescent health. Next, please. We have Dr. Chandrakala Maran, who's the president of COGS, Conductive Society, and she too has been holding a lot of different posts. Especially, she's active in the Yuva Foxy conference in Trichur. She received Best Doctor Award from Dr. MGR University in 2012. She's published many papers in journals. And we have Dr. Radhika Gauri. She's also has special interests, and she's a clinical lead in ESI Hospital, Tirunelveli. She's also has a lot of experience in this field in OBG and member of various societies, and she's clinical lead at Tirunelveli ESI Hospital. And her special interests are in high-risk pregnancies, adolescent obesity, and laparoscopy. Yeah. So, yes, we will go to the topic.
Okay, we have the panelists have all given the questions before. So I have put the name of the doctor who's raised the question also on the slide. I request the doctor who has asked the question.
Gayatri.
Yeah.
Okay, so the doctor who has made the question, she will start the discussion, and of course, all of us can chip in. So for the first question.
Yeah. Doctors from which field are the most affected in medical legal cases in India?
Yeah, obviously it's in our field of obstetrics and gynecology. The reason for that is that we are dealing with two lives. One is the woman's life and the baby she's carrying, fetus she's carrying, and therefore it's two lives. People feel, yes, it's simple. Deliveries are very simple. And they, especially in India, they think it's a norm that they need to have a normal delivery and it has to be a male baby. It's very difficult to satisfy both options. And when they are not satisfied, they lose trust. And that's why litigation comes in. Yeah.
Every day there is 25 million, every 67,000 deliveries are happening. Almost most of the deliveries are somewhere medical help is given. So we are more attached to the persons, and then they are physiological. So people expect everything should be normal. And with the medical help also, why do you want to lose life or have some morbidity? That is an issue.
In fact,
And
I'd like to
especially when
add
they
here.
want only the positive outcome from us.
Yes,
Yeah, that's right.
When they go with a heart attack or a stroke, their acceptance is much better than when they come for a delivery.
Yes. And that's why we're having out of the litigation, 30% of the cases are in obs and gyn. And orthopedics comes next with 15% of the cases. So that's high. This double this number of second persons field. That's why OBGYN is a litigated field now.
And probably that is why we have the CME today to dedicate it for that.
And moreover, I would also like to tell you that you don't have to really sometimes be frightened. When it goes to the court, only 30% of the case actually comes as compensation for the patient. 70% they accuse the doctor of any charges. So therefore, it's not that it becomes a court case, you will be accused. No.
Yes, sir. Yes, sir. More than
Very low, very low
65
chances.
to 7. Yeah, 65 to 70% of cases without proof, their cases are getting dismissed.
Dismissed, acquitted. So therefore, we don't need to actually get too frightened. It's over. In India, it's we are still protected, I would say.
That's true. So for as far as documentation is concerned, how many years do we maintain our in-house case sheets, and how is it different for OG?
Yeah. See, one thing is today we are going into an electronic world, IT field. So all our records are to be maintained in electronic form in some way or the other. It's going to happen and we need to accept this change. And when it is kept in electronic form, it is much easier to preserve. For lifetime, it is kept. You have iCloud, everything is preserved for many years. You have diskettes, I mean, different ways of documentation, preservation, and there are people who are also specialized in this field, and therefore it's not difficult for us to take their help. And it's very important. People should understand, doctors should understand, document is protecting us. It is what good work we have done. It will tell you, it will protect you in the court of law. So the longer we keep a document, the better it is. But I will also like to, at this point of time, just to tell you what the Act says. Now you have a Act. You have the PCPNDT Act is mandatory 2 years. Then you have the Consumer Law, Consumer Code that says 3 years. The MTP Act says 5 years. You have the ART Act says for 10 years. You have the Surrogacy Act saying for 20 years. So you have different acts, but just remember, the longer you keep your record, because it's going to protect you. Documents are for your protection, not the patient's. So it tells what good work you have done, and having a complete document is very, very important. And before you give to a document to somebody else, make sure it is complete. You can always take a senior's help, get it ratified before you give it to authorities.
So the reason why I brought this question up, sir, I have heard of a case where the child was waiting till it became 18 years and then
yes, that's what
the
18 years
who delivered the child.
3 years after becoming adult. No, 3 years after becoming adult. That is 21 years.
Yeah.
3 years, that is the Consumer Code says, up to 21 years, you have to maintain all case process. But more important is lifelong is what you need to keep. And today you have a system to keep it. You have electronic case records. Let us accept that.
Sir, which
The
documents
same
we can-
question was raised by
No, no,
Dr.
yeah,
Shanti
there is
also.
another aspect that is with reference to CTG, because as Madam rightly said, the mental retardation, all these things, they can even claim after becoming adult, that is 18 plus 3 or so, like that.
21,
and all.
yes. Yes.
Yeah. So the CTG, we have to keep it both in electronic method and also the paper, which is keeping the paper, it's
Difficult.
naturally it
Paper
will fade
will
away.
get erased.
Fade away. And that is why. And second thing, the keeping the, I know the law says 5 years, 10 years, the MLC cases 10 years, and my MTP Act all 5 years. Surrogacy Act is a maximum, which is 25 years. But it is easy to say that keep all electronic iCloud and all, but there is a difficulty. And as a years passes, even we have to, though the law says, the law is silent about the keeping the OPD document, we are supposed to keep the OPD documents also. So it will come in the bulk. So by this discussion, we can even request our association to help out, because for this medical legal cases, the indemnity cover, the FOXI has given out a nice program with the ICICI, and it is good. So even for keeping the document, we can, our association can help us, because it is becoming very costly to save EMR, electromedical records for years together. As you are telling, it should better to be on a long time as much as possible. Even Nagpal sir says, Neeraj Nagpal sir says, try to keep it as long as possible. Even if you say in public by giving newspaper that this hospital has destroyed evidences, to save ourselves, better to keep it as long as possible. So if you say as long as possible, naturally that electronic, the load is very high, data is very heavy. So I think we have to have some other arrangements with a lesser expenditure. I want to say that. And giving the details in OPD, the government says now, if a patient coming and asking the OPD details, within 72 hours, we have to give inpatient thing also within 72 hours, we have to retrieve. Means if it is electronic, it is easy to retrieve. And again, giving such a document to insurance persons and other relatives, we should be very careful in giving the patient's details, because later patient can sue that why you have given my documents without my consent, all these things. Yeah.
It is a personal property of the patient. That
Yes.
you must remember that. Whenever you're giving, you
There
should
should
get
not
the
be breach of
consent of the patient.
confidentiality.
Yes.
Yeah, patient's consent is very important before you give that document to anybody.
Sir, but by storing everything in the iCloud and other things, are we not subjected to the risk of hacking?
Yes, sir, definitely,
Yes,
madam. That
yes,
is why.
yes. That's why that's a big problem in our country. It is hacking is taking place, especially with government records. It is taking place, and this it is data means money. It can be used for different purposes. So yes, it is hacking is taking place, but then you are in other security methods are coming up. People are using research for research
Making
work
it
is going
minimal.
on for making it secure. It is
Yeah.
changing. IT world is changing.
Hopefully.
With reference to hacking, sir, we
Yes.
are going to have a contract with the person, whoever, maybe it may be iCloud or any agency, so
Yes.
that the contract will protect us in case of any problem
Yes,
issues, and
problem.
that should have a class to include that also.
Yes.
Dr. Radhika?
Yeah. So patients, since I am working in ESL, we are actually, the patients come to us with different treatments, managements, which sometimes do not fall under the guidelines or which are not appropriate, but then they come to us for leave based on the treatment. Are we bound to give?
Yeah.
And if we give, are we bound legally in any way?
Now giving a medical certificate, what you're talking is medical certificate. Let's go.
Yes,
A
sir.
medical certificate is to be given by a person who has rendered the service. So therefore, it can be given only by a person who is given the treatment, because he has to give based on the facts of the treatment, what he has given. So a person who is not given the treatment is not liable to give a medical certificate. So as far as possible, if the person has undergone a surgery, it is a surgeon who has to give the medical certificate. Insist on the patient going back to the person who's done the thing, because he knows what are the complications. He might not have written everything in the case records, but then he knows inside him that this possible complication can come about, like pulmonary embolism. Something can come about if you're giving wrong treatment. So therefore, it is for him to decide what are the tablets to be given post-operatively, medicines to be given, and his responsibility lies till the patient recovers completely from the treatment what he prescribed.
If it is surgery, it is relatively better because the
Yes.
patient will have scar. There is an evidence that to say that the patient might have undergone that procedure. So, with preference to ESA, patient will insist to have a leave on that purpose. So, in that situation, if there is a surgery based on the surgical scar and other examination findings and the leave certificate given by the private practitioner, based on that evidences like that, we can write
Yes.
because we have
And
to help the patient also. Yeah.
Yeah, but very important when you write a medical certificate, certain things has to be kept in mind. The doctor who's giving certificate, that person's registration number, address, qualification, and all has to be done. And also the patient's identification. You have what is the patient's identification point has to be how you identify the patient, what is the age of the patient, sex of the patient, address of the patient, all that has to be written. So it's very important that a medical certificate is a legal document. It's not to be given just like that because the courts rely a lot on a medical certificate. So therefore, we should take it very careful consideration should be made to all the points. Are you giving to the right person? And a certificate is only applicable for 14 days. More than that, you shouldn't, because anything can change after 2 weeks.
Yes,
So
sir. I
that's also
totally
very
agree.
And it's very important for us to not to give it to anybody other than the patient.
Yes.
Sometimes, especially in this delivery, post-delivery and all, to extend the maternity leave and all, the husbands come, the brothers come. It's very important to look at the patient and give.
Yes.
There was an instance somewhere where the patient was very sick or something, or probably passed away, and somebody had taken a leave letter for them from some other doctor who had, apparently delivered and all. If you listen to all those things, it's quite scary.
No, that's why you need to give identification mark that you have examined the patient and you found these identification marks. It's not just we just give it as at least one identification mark of that patient you have examined should be written there in the certificate.
Yes, sir. I totally agree with you, sir. We also had a bitter experience in that just having a photo in ESA, we used to have a photo. There was a forgery done by a patient with a daughter's photo was changed for the treatment for the daughter. When the mother is IP, the photo of the daughter was changed because of the resemblance of the mother-daughter. We thought of carried away, but after that identification mark, we could because the surgery was a very costly procedure, so we were very keen in selecting the patient. So we narrowly we escaped. So as you rightly said, identification mark of the person or patient is very, very important.
Okay.
So we had one antenatal patient. Sir, am I audible?
Yes.
Yes, sir.
Yeah. So she was gravid for para 1, live 1, abortion 2. Those two were also MTPs. Previous preterm LSAS. Now she's 18 weeks. She had a diaphragmatic hernia with a left lung collapse, gastric volvulus with SpO2 of only 92%, and she could only sit. She cannot lie down. That much of breathlessness she has had.
Yeah, she doesn't want that
MTP.
she wants MTP. So therefore,
Family is not agreeing.
Yeah, but then MTP is a
Should we do
woman's
or
right. No, I'll tell you. First is MTP Act has come in to empower all women to take the decision to carry the baby or not. It's their right. Nobody else will can take that decision. Even husband cannot take that decision. It is her right. If since you have clearly said that she wants MTP, you can go ahead with the MTP. But first is her condition, her physical condition, her medical condition. Since you said that she's having the diaphragmatic hernia, you have to sort of treat that medical problem with the help of a physician, multi-specialty unit in a healthcare big facility, tertiary center. You can go ahead and do the termination of pregnancy. After 20 weeks, only her consent. That's it. You don't need anybody else's consent. And her desire to terminate is enough. That's an indication.
Yeah, actually, she had this. She could not afford treatment at this tertiary center where I'm attached to, sir. It's a KG hospital, corporate hospital. So we had referred her to the GH, and then I think apparently they had undergone. She was not willing. The thing was, she was not willing to undergo surgery for diaphragmatic hernia. She's telling all through the life I've been like this and I wanted to continue like that. So that's why we could not either convince her for any treatment at all. So we had referred her to General Hospital where they have done MTP. Again, they have done the repair of the diaphragmatic hernia as well.
Oh, yeah, that's good.
Yeah. Thank you, sir.
Dr. Geeta? Dr. Geeta? Okay, probably network issue. We have here a primary patient attenders who is
one minute, ma'am.
Yeah.
Sir,
Yes.
let me ask, sir. So a primary patient, this is the real scenario we had, sir. She was a primary, LSCS was done, and she had atonic PPH, which was not controlled with medical management, and all conservative methods were done. And as a final result, baby was also had a severe birth asphyxia. We convinced the attenders for hysterectomy as a life-saving procedure, but still they could not able to give consent for that. How do we go about in that case?
Yeah, so it's a very good question. It is likely to happen, especially if the problem is if she is, as you say, she's a primary and she's a baby, she's going to lose the baby also. So the patients, attenders are going to be very upset. A likely scenario for a mob violence also, this I can tell you, because they've completely lost trust in the doctor for what they've come. It's an unexpected problem that has happened. But then, because nobody expects this to happen, that patient can die. But then it is your communication that is going to help in this case. Your communication with the patient, build up the trust that you are doing the best for the patient. So first thing is communicate the problem to the patient. Bring to patient's relative, especially the husband has to be involved in this case. You call him, talk to him, tell him this is a grave situation where two lives are is in a problem, and maybe you can only save one life, that is the mother's life.
Sir, we are in OT now. After talking to husband, still
Yes.
he's not
No,
accepting. What
yes,
should we
I'll
do?
tell you, because this case has come up once in a national forum, national dispute where Dr. Kanitkar has passed an order. It was when this was between Ahuja, one patient called Anuja Chowdhury, you can WhatsApp up and say, and versus Samir Hospital or something, where he has clearly said, when you want to save the life of a patient, you don't need to take consent from anybody. It is a principle of necessity we are acting. It overrides the autonomy of the patient's relatives. They do not know what actually is happening. They might be in a shock. Right now the patient is at shock. When we're talking about consent means you need to take the permission of the patient. Here the patient is in shock. And the next person who is the husband. Now the husband, tomorrow he will tell, we trusted and came to you. So you are supposed to take that decision for us. So his decision at that point of time could be wrong. So therefore, you should convince him that his decision is wrong. And
because the
as a
baby is
doctor,
also not well, they were not
yes,
able
I
to
understand. But the doctor has a duty, and that duty
Towards life.
was to saving the life of the patient. So they can go ahead. And
So even without consent, we can go ahead with
you can go
hysterectomy
ahead.
as a
But more
life-saving
important
procedure.
is
Ma'am, if our
documentation.
documentation can prove that we did it to
Documentation is-
save her life,
Yeah.
no one can question us.
Yeah, and very important is documentation, because court will ask, really, was it a necessity at all? Is that a principle of necessity, saying that to save the patient, have you taken all the conservative procedures to maybe before doing hysterectomy, or the medical management has faced? What are the medical blood transfusions? Everything failed, and then you have resorted to this as a last resort. If this is the last resort to save a person's life, then this can be done. So hysterectomy can be done, provided you document the other procedures, medical procedures which are failed to save the patient's life. Which has led to deterioration of a patient's condition.
Thank you, sir.
So
Sir,
that
can
is
we
important.
discuss this in a private and government setup? A government setup scenario is different. The same scenario in a private means
Yes, it's very, very important, because first thing is you should not miss out. The first part is your communication. You should have a good rapport with your patient. They should trust you that you have done everything possible. You should communicate them. You have done everything possible in the right process. And this was unexpected even by you. You wouldn't expect a person to have PPH. You should show them that why PPH has come, why this thing has happened, why it was atonic, why the uterus is not contracting. It's better you call a lady attendant inside, show them the uterus is not contracting, show them the procedures, is bleeding, how much pads have lost. Once they see with their own eyes what is happening and the efforts you're taking to save the person's life, they will be quiet. When you're
And
hiding
we have to make them
something,
understand, ma'am, that
yes,
most lowest risk patient can become the literal
yes,
high risk in no
high,
time. There is
no
no
time.
word called
Yes.
no risk in our profession. We
Yes.
have only low risk and high risk.
High risk. Yeah.
And that you have to show to
There's
them.
no terminology called no risk.
Yeah, and therefore you need to show to them. You can't say, you can't come into the labor room and say everything is happening inside. That's when suspicion comes in. You call one of the ladies. You call one person who can understand. Make them see what is happening. And once you communicate your empathy and your efforts, what you're doing, they will be all right. The trust is very important. Today, litigation is coming up because people are losing trust.
And I truly, second what sir said, it's the communication. It will be on us to tell those patients that by doing the hysterectomy, we can at least save the mother, or
Yes.
we'll end up losing both.
Yes.
But the whole problem with our society is, for them, the woman is nothing but a birthing machine.
Yes,
Most
sir.
of the cases.
Yes,
So
yes.
they are very reluctant to let go of it.
Yes.
They're more bothered about the baby all the time.
Yeah.
They don't value the mother most of the time. They think she's only, the only to give birth to the.
And remember, in the court, negligence comes in only when the mother dies. So you should let the mother, any cost, lose the mother. Do what you want to save the mother.
Yes.
Hysterectomy,
So actually,
any
in
internal
this-
artery ligation, anything you can do.
Actually, true.
And
Given
it's
today's
better.
circumstances, how the private and the government are, going hand in hand, they are trying to ask questions for each and every maternal near miss and miss cases. I think for this case, if we don't do it, we'll be questioned severely
Yes. You will be losing the mother.
by
then we
the
have
by
to
the
answer.
district collectorate and all those things.
Yeah, yes.
And always you take the opinion of a senior doctor also, because that's where that's also comes in. If you have somebody senior to support you and saying these are the right methods you have done,
We have also
conservative
called another
methods.
person to help us.
Yes. So all that helps, and people will be
We'll have
convinced.
more number of people vouch for us.
Yes.
Yes.
Okay, that was a very nice discussion on this case. Dr. Adhika Gauri, it's your question.
So there is another, nowadays in many periphery, there are lots of surgeons who operate on women without doing a biopsy. They take away the uterus. They just do a hysterectomy. And then again, we have an issue that the patient comes back to us. And when we find that she's sick in the post-op period, we try to investigate and we found that she had endometrial cancer and it spread all over. It's stage 4 cancer. Now the patient has not been told anything, and she's like a villager, rural. She's it's very pathetic to think. How do we go about it now?
See, you must understand that obviously certain pre-op procedures are necessary. If endometrial biopsy has to be taken, it has to be done. If the endometrium is very thick and you have not taken a biopsy, that's a part of negligence itself takes place. So,
But it is the general surgeons nowadays. Most of the time, in
yes.
some private nursing homes, they do not follow the protocol, or they do not know the pathology. Also, if the woman goes with bleeding, they just take off the they just want to straight away do the hysterectomy.
I know they are ghost.
This scenario is very common in the suburbs.
Yeah, I know.
Exactly, the villages and the
I agree.
periphery.
The surgeons are the ghost surgeons. I mean, that's what they say is ghost surgeons. But then it is important that the person who's calling the surgeon, it is their responsibility. Vicarious reliability comes on them. That this is their patient. It's important they do pre-op procedures, all this before calling. The surgeon is responsible for surgical care. But then more important, who's called the surgeon? Who is the primary physician? So why did that primary
Who's the
physician?
one who decided the surgery?
Yes, decided on surgery. Yes, that person, it becomes their responsibility.
And suppose, Nejamalme, if the patient is going to come and ask us some opinion on this, ma'am, I think we have to, at least we have not been there with the patient when the whole thing happened. So tell them that, I mean, I was not there, examined you, I don't, so I will not go and comment on that. Today's thing, I'll tell you.
Yeah, that's what we had to do that. But in this case, the patient was like she was ignorant. But anyway, we explained to her it is stage 4 cancer and all that. And then she agreed for chemotherapy. But if it was a educated patient,
then primary consultant will be held responsible. Vicarious responsibility will come in.
Okay, sir. Thank you. Thank you, sir.
Okay, so this is mine from my side. In different level of medical practices, we have a different understanding of what to maintain in a consent. In fact, in certain consents, I've just seen this like under I'm so and so, and under anesthesia, I'm willing to undergo so and so procedure. That's all. Nothing else written. So, what are the very important things that we will have to have in a consent when it is going to really be meaningful and protective?
Yeah. Now, see, many of the litigations are happening because of not taking proper consent. So that's one of the reasons why people get into trouble. Informed consent is very, very important. Word informed consent means you're giving all information regarding the treatment. What is the purpose of the treatment? Then what are the risks? What are the benefits? What are the alternative treatments that are available? And what happens if you don't accept this treatment? This is to be told to the patient. And consent means you are giving the decision to the patient to take. So you don't have to take. Suppose you're doing a cesarean, you're telling them the risks, everything. What is different between normal delivery and cesarean? You're telling everything and then asking the patient to take that decision. So that is most important. Today, we have to respect the patient's autonomy and allow them to take the decision. The consent is very important. And this consent can be of two types. It could be implied consent and it could be an explicit consent. Implied is whenever they just come to you itself and ask you, that is implied. Coming to you itself is implied. You can examine them because they're coming to you. But when you're doing any invasive procedures, you need to
the mic on.
Explicit consent in writing.
Faculties, please mute if you're not talking.
Yeah. So a consent should be in writing, and you should as well, especially if it's an invasive procedure, you're doing a surgery, a consent of the patient should be taken in writing, and a witness, ideally at least one or two witnesses, is to be signature of that, to say that is the signature of the patient. So consent is very important, and consent should be in the language the patient understands. And you should also make sure the patient can comprehend what you're saying, and it is in the language of the patient who understands. If you are talking in English and the patient does not know English, it's not a consent. You need to talk in the language of the patient. If you need, you take the help of a translator. If they are coming from another state, you should take help of a translator and tell them these points. What the reasons for surgery, purpose, what risks. Risks are very, very important. What are complications? What happens if you don't do the surgery, and benefits of surgeries? All this has to be told.
Yeah, I think we can even have a form with the places for all these things. What surgery has been advised, why it is advised, what are the complications, and what happens if you refuse. I think we can fill in the form and keep it for us for a consent.
See, today, even this written format is not actually very accepted. You write in handwriting, in your own handwriting, that's the best. Even if it's simple, you have explained everything, but it's very difficult. But then
Sir,
that
it
is
is
the
very
best, and
difficult,
because
sir.
it has to be specific to the surgery. See, most of the printed forms are vague. They will tell all complications. They are not very specific for a particular surgery. Sometimes surgeries can, I mean, you can have for cesarean or hysterectomy, but if you're doing some specific surgeries which are not usually done, then it's better to have it a handwritten format. Spend some time, think what are the possible complications, and write it down, because each case can vary. Patient's complications can vary. A general format is not much accepted.
Sir, the procedure specific Foxy consents are good, sir. We
Yeah,
can
they're
use.
good. Yes, but
We should,
yeah.
Yeah, we can use
and
that,
sir,
sir.
in this era, what is the place of a video consent, sir?
Yeah, that's very important, because we are going into IT world. It's AI is also coming into this our field. We need to accept this change, and telecommunication, telemedicine is now acceptable in the courts also. So any form of communication. Now, when we talk about telemedicine, consent uh, could be audio. It is also all based on different types. I like to first highlight what are different types of telemedicine communication. First is you talk about the mode of communication. It could be video, audio, or text, like you have chats, emails, and all. There are three types of communication. And what is the timing of the communication or information transmitted is also important. It could be real time or it could be asynchronous. Real time is video. You're talking and somebody is at the same time they're also giving you the consent, oral consent. Or it could be in a text for asynchronous. You're just sending email or chat and they're signing at their own different timing and sending. So it's not at the same level between the two people. Then you have the purpose of the consultation. It could be first consultation. Video consultation could be first consultation. That's a very important consultation. Or
So
it
in
could be a
many,
follow-up consultation. Follow-up is only when you're already seen the patient, you can remember your patient, and then certain drugs can be given at that point of time. So for first consultation, it's always better to be in a video consultation. You can't use audio or text for first consultation. First consultation should be video consultation, because you're seeing the patient
Identification of the patient.
and identification and then giving.
And the court of law, we have no problem, no, sir. Video
Yeah.
consents are accepted.
Yes, video consultation is the best, I could say. Then you have other type of consultation is the interaction between the person to person. That is, it could be between the doctor and the patient is one type. Then it could be between the doctor and the caregiver. The caregiver could be a family member. Or the third type is between a doctor and another doctor who's asking for any help. So that is also acceptable in the court of law. And the fourth type is today corporate companies are doing it, corporate hospitals are doing is between a doctor and a healthcare facilitator. They're having a patient next to them and a nurse next to them who's examining the patient and then giving those details to the doctor, and the doctor is giving medicine. So these are the different types of communication in video conferencing, which is acceptable in the court of law.
this video consent is mainly it is being used in the corporate hospitals, and
Yes.
wherever possible, it is definitely useful, even for pre-anesthetist consent and surgeon's consent, or for most important and complicated cases, it is being obtained, and it is very useful because patient later cannot deny that I have not been told about this disadvantages or alternative procedures. Which is very, we used to say in simply, it can be done by lap or open or what advantage disadvantage, but the patient denies. So the video consent is very useful nowadays, and it is gaining importance.
But the other very important thing is identification of the patient. When you're doing, you should record whatever you're doing with the video conferencing. Whatever message you're giving, it's important you record that session and you identify your patient first, and you identify yourself. The doctor has to tell themselves, and their qualification and the registration number is very important before you start the conversation. That's very important. And obviously consent is very, very important in this thing, and implied comes
Sir,
in.
I'd like to quote a case, sir, now. It was an IVF center, and they have done, the mother was a little old, so she had poor ovarian reserve, all those things, but she wanted only one gamete when all the options were given to her. And they have gone ahead with the transfer, and she didn't get pregnant. And in her OP sheet, in the doctor's handwriting, in her OP file, there was a paper where there were diagrams drawn by the doctor to explain what happens in donor embryo, donor oocytes, donor sperm, everything. She did not become pregnant, so she went ahead and said that she was guaranteed something which was not actually done. And despite all these, in the doctor's handwriting OP sheet showing that so many things, the case was decided against the doctor, saying that the whole information was not given to her because she just told in the court of law that she didn't understand.
Yeah, see, that's the thing, no?
Would
Many
my
many
experts
problems
comment
are,
on it?
yeah, many problems that are going against doctors is because when the patient denies being understood. So it's very important that you get the consent of the patient, that they've
Consent was there,
understood what
sir.
to.
The consent was there. The consent also told that this particular own gamete gives you the least thing. And in that box where it was written, they have ticked that it's the own gametes and all those things. Despite the consent form being available, despite the OP notes showing that the doctor's handwriting everything was there, the case was decided against the doctor.
There might be
Just because
different
the
reasons.
woman said that she didn't understand.
Yes, so if it is the language, so it's very important that you know what
It's
is
in
the
Tamil,
language.
sir. It's in her native language.
Yeah, but then if she
I really
the
don't know
consent,
what went on in the court, but that was very,
so
very
there must be
absurd.
something else that is irrelevant, that is
Preoccupied,
yeah,
biased judgment,
biased
maybe we have
decision,
to
yes.
appeal. We have to
Yes.
appeal because in our country the consent is real and valid. If the
Right.
person
Yeah,
signs,
the same court, same case in a lower court, in a higher court will
Yeah.
have exactly
Different,
opposite things, and
opposite
still that's
judgment.
not okay. That's still okay and not negligent.
Yeah,
Most
so
of the time the patient might have been educated patient also, because they have come for IVF, all these things, and all. Most probably should have been at least to some
appeal.
extent
No, ma'am.
literate.
No, ma'am,
Correct.
not that much, ma'am.
No, there
Whatever it
must
may
be.
be, they have
It can go
to
on an
sign means
appeal.
they are understood. That's
Yeah,
all.
it can go on an
Yeah,
appeal.
they are
and,
going on appeal. Appeal is not yet over, sir. But the initial thing itself was very surprising, because I thought this is a straightforward to be dismissed case. So when I was informed that it went against the doctor, I was shocked.
We need to see the facts of the case. What was actual message that was given to the patient, and why this case went.
Actually, that was the reason why I took the question of a video consent, because probably when she said she didn't understand a video consent, if it was there, maybe will be on our side.
Yes, so it should be. That's why the video consent should be recorded. Maybe that was not recorded.
Sir, in this
Consent should be recorded.
No, that was not a video consent at all. But I think that is the way forward to escape from these kind of things.
Yes.
Interpreting it in however they want.
That's where exactly I said how to keep such so much of documents in a soft copy. It is really getting a problem, because we are facing this problem even now, even for we have association, all these
One
things.
of the doctors just raised the point of it becomes very costly affair to either. But when we go and tell this to the the government people or the public things, they say that you are all charging. No, let them do this also. This is
So
exactly the attitude we get, ma'am.
Yeah, that is where our association is talking about the scientific costing. So we are not getting that. So that's a different
so what?
topic.
As if you are doing, you are taking money, no? So do this also. This is
Yeah,
exactly the
scientific
answer we
costing.
get.
Yeah, scientific casting is a different topic. We will deal
The
it
public
later.
sector, that's the exact tone they use to talk to us.
Yes.
Right, there is another way out. What we do in our hospital is, if the patient not only for this procedures, but for everything, we make the patient or the attender to write, whatever we have a register. If the patient refuses admission or any referral for opinion, we just tell them that I have this high blood pressure. I know that the doctor has explained to me all this in her own handwriting. If she is not educated, maybe her husband or somebody, but they should write it on their own handwriting, and then they should sign it and write their address, phone number, and everything. Because of such situation or whatever, in most of the times they refuse. When they're high risk, they want to take another opinion, so they try to escape.
You ask them for the sign, they get perturbed.
Pardon?
You ask for their sign, they get worried now.
Yeah, then but they have to do it. Otherwise, we'll say, okay, then we can't. You have to sign it. Then they worry, but then see at that time they agree to admission, they agree to all the procedures because they understood the thing now. So we make them sign. We have a register. We make them do all the write everything whatever we said in front of another witness also.
Yeah,
Yeah.
we'll go to the next question now, next discussion.
Yeah. So it is working most of the time. But anyway, we don't know what to do.
Dr. Adhika Gauri, you can take your question.
Yeah, this is the usual scenario, sir. Vivek, sir.
Yeah, go ahead.
One of the ladies got pregnant after 5 years after sterilization, pupil sterilization done by one of the colleagues. And then she comes back at 4 to 5 weeks. And the radiologist.
Excel தான் correct.
Ramani madam, please mute up, ma'am.
So the radiologist just says that there is a gestational sac, and the patient assumes, even though we have explained to her clearly it could be an ectopic, or she has to
Dark
be
color sir.
nearby tertiary hospital. And we
Ramani madam, can you please mute your audio, ma'am? Ramani madam, please mute it. Yeah, we'll go proceed. Yes, madam.
So in spite of explaining, patient refused to follow, and then she came after 6 to 8 weeks. Actually, 8 weeks she came, and then she did not have any symptoms. She thought it was an intrauterine pregnancy, but then when we did her beta CG and we told her to have another scan, she didn't have a scan. She only had the beta HCG tested, and she went back. She never came back for follow-up. And then she was found to have a ruptured ectopic, and she was treated at a private hospital, sir. And then she was claiming that she had filed a case against the doctor who had done the sterilization and also against the hospital.
Yeah, see, it's a good question because this is a very common thing that is happening today. Pregnancy following pupil sterilization, when that happens, the first thing the patient is to go to the court. And in this case, she has had a ruptured tubal ectopic. All the more reason that she's agitated and she will go to the court. But remember one thing, the courts today they understand the plight of doctors. They know that pregnancy failing pupil sterilization happens, so liability is not there. But at times, like recently in a case where Kanyakumari in government hospital in Kanyakumari, where the court said the state had to pay for the compensation of 3 lakhs to the mother and 10,000 every month for the child when failed third pregnancy for delivery of the third pregnancy, third girl. Now, this is called non-fault liability. No fault liability. So, based on compensation out of sympathy and empathy for the patient. So, remember, if at all compensation is given, it is only for the sake of, it's a very small amount and it will be to relieve the problem of the patient. It is not because of the fault of the doctor. So in this case, the two things you should remember, obstetrician is not at fault because people's pregnancy following pupil sterilization happens. It is court has understood it happens. It is not the fault. So there's no negligence in the first place. Second point is the doctor has asked for a second scan, referred for second scan, and the patient has not taken it. So here again, I emphasize on documentation. Documentation is very important and you should document. Documentation will save this doctor. If the doctor has referred, they're saying that I have asked for a referral and the patient has not gone on there, then the fault goes to the patient and not the doctor. So therefore, definitely the referring the consultant will not be held responsible. Even the performing doctor will not be held responsible. The only person may be a radiologist for missing out ectopic, but then again, he can also get away saying that it was very early pregnancy. It is not that much. So therefore, doctors in this case will not be held liable. If at all they are liable, it is out of empathy and sympathy for the patient, and very small liability will come. It is not a very big amount.
Dr. Shanti?
Yeah, why gynecologists are most affected, partly we have already discussed.
Yeah.
So what is the increasing percentage of cases against them? And it is previously it was orthopedician, number one. Now we have surpassed them and we are number one now with the almost 26% of all cases, where the orthopedicians number is around 14% of all cases. But mainly the number of cases against which we are punished are regarding the birth asphyxia, postpartum complications, like we discussed now, the PS failure. And one area which I wanted to say here is the USG. Most of the places, the USG is written by obstetrician, right? No anomalies, all these things. Where we are getting caught. I think we have to be very careful
Yeah,
about
we
it.
should not comment on anomalies at all.
So we can do FH location, heartbeat, and then placenta location, many things. Rest of the thing we better do it
Actually,
done by
law. No, ma'am. Actually, by law, we have every right to do it. So if a
Yes.
doctor does it, we can't really blame her. But this is for her own benefit. It's not
Yeah.
anyway our cup of cake. So why
Yes.
should we take the unnecessary headache of it?
Yes, and then that amount is very heavy with in reference to USG, all these things, the radiological punishment, the amounts are very heavy. And second thing, if a person is very well trained and if they are very confident, then they can do anomaly scan. Otherwise, they can at least do the anomaly scan by the radiologist. Rest growth scan and other viability scan, all these things can be done by our physician. As you have rightly mentioned, we are also got a right to do it. It's not that we don't know all these things. Only with reference to anomaly scan, and then we have to emphasize on our patients that there is something called the anomaly. We can evolving anomaly, which we can happen even afterwards. Even there,
When
there
we
are
document the
cases.
scan report, I would suggest that we write that these things are normal and they have been seen, rather than write a word called no anomaly seen.
Yes, but that's
I
the
think
fifth month anomaly scan better not to be done by us, because now the thing, so many cases are coming against it, and it is real headache. The other anomaly, other scans like first month scan, that is location for viability, placenta location, and growth scan, all these things can be done by us. Let us leave this to anomaly scan to because it takes time also, more than 1 hour. We have to we have to sit with the patient for more than 1 hour. Baby have to move to show all their parts and all these things, real headache. And after analyzing the cases which are filed against the physician, I just want to share this piece of information to this through this program.
Sir, do you want to come in, sir? Vivek, sir?
Yeah, that's important that and even cases have come when sometimes when radiologist misses, you can also say because the amniotic fluid was very less, something like that, and why the case was missed out can also the courts are also
So it's important to have a literature which says what percentage of cases are missed
and obesity
from a
of the
radiology textbook or something.
Yeah, and if the patient was because of obesity, you were not able to see properly. There could be many reasons why an anomaly was missed out. So that's it's important. Documentation is very important.
Yeah, it is I see as
The
a
doctors
preventable
cannot
one.
be penalized for complications or what is expected.
Yes.
We can be penalized only for frank negligence.
Frank negligence. Yes.
For example, the cases against physician, if we analyze that PS failure, we cannot do anything.
Yes.
Like that post PPH, we cannot do anything, and like that birth asphyxia. The one aspect where we can do something is with reference to USG. That is why, but we cannot do away our USG, because this is our supposed to be our sixth finger. So we are always with the doing USG. So only with the anomaly scan we can do with the radiologist. That's my point.
Yes.
Yeah, actually, given the examples that you quoted, ma'am, had the patient required a hysterectomy and had we not acted upon it and done it, and we had let something happen to the patient, then we are more likely to be sued.
Yes, patient should be alive. Then patient should be alive. Then losing an organ,
whatever we do with a goodwill to the patient, I think it's okay.
Yeah, if the patient is there to fight with us, that is fine. If the patient is not there, then all the more everything is becoming a problem.
Yes.
Dr. Gayatri, your question. Madam, are you there?
Gayatri is held up with the delivery. So she.
Okay. Fine. Any of us.
Dr. Chandrakala and Dr. Geeta is there, no?
Yeah.
Okay, we'll go for another. Dr. Chandrakala?
Yes, ma'am. Here, madam, this is one of our colleagues' patient. She was para 2, both was cesarean section. During the second cesarean section, bladder injury was, there was a bladder injury, but then it was recognized only on the second post-operative day. And they had gone ahead with the urologist, they had done a laparotomy and repair. And then the patient was discharged on the post-operative day 8 very comfortably. She did not have any issues at all. But just the question is, can the patient challenge us medico-legally?
Yeah, see, any case, patient can challenge. That is another thing. But then will it stand? No, because
Will it stand? Yes, sir. Will
it
it
will
stand?
not stand because the doctor has taken all the precautions. He has repaired done.
Yeah.
And the problem, see, litigation comes when you have failed to recognize the problem. Negligence is when you have failed to recognize the problem. Here, they have recognized the problem and repaired it. So there's no problem. But can they put a case? Yes, they can put a case, but it will not win.
Yeah, they did have sleepless nights because they were worried whether they'll put a case. In this, another one question, sir, should we offer any what is it?
Compensation.
Consolation on the thing, what is it? Charges. Reduction of the charges because a mistake had been done.
No, it is
I mean,
not
had
a
happened.
mistake. First of all,
No.
don't tell it's a mistake.
Huh?
It happens, but then, yes, you have to have empathy and sympathy for the patients. There's nothing wrong in giving a concession. There's nothing wrong.
Yeah.
Best practice is always, if money is the thing, one patient you can do free, nothing will happen.
Yes.
In this
Sir,
case,
we have
I
to be
would say
careful here, sir.
careful.
If we do free, then they will think that some mistake has been done. So it is an Can I put a accepted and question here, sir? Yeah,
No,
if
no.
there is a case like what ma'am said, there was some problem, and we directly give either we put down the fees or even as you say free case, will it stand against us in the court of law, sir?
No, no, no. The
Definitely.
court,
No, sir, that somebody may interpret in that way also because
they may-
because generally the teaching is don't do that. So when
Yes.
I was in such a situation and when they were demanding a little reduction, I made the family give me a return requisition for waiving charges.
I'll tell you, even the court says that even out of court settlement, when there's no grievous injury, like if there's no death, you can always, if it's a simple injury or something, you can, mediate with the patient, and even the consumer court has said, you can mediate, settle it. So settling is what? Waiving all the fees, nothing. That will not go against you. Please, it is simplest and easiest. People in India especially get angry based on charges, billing. Billing is a big factor. So if it's in your hand to waive off something, waive it off. Don't dare, it is not saying that you're guilty. You're more empathetic to the patient. Guilty is a different, it can be proved in a different way. If there's negligence, negligence is proved. There's nothing you cannot, in a court, you cannot overcome negligence. It's not, fees is not negligence, but overcharging is negligence. Undercharging is not negligence. So you can always undercharge and send them off.
Yes, sir. The rules and regulations to be kept in mind to do the medical termination of pregnancy. So these are all the different kind of patients. They come to us with a trouble. Pregnancy, major patient that is above 18, unmarried status. And recently in 2023, last year, we had a case in Tamil Nadu and one of our physician got arrested because of this kind of an issue. So I just wanted to bring this point so that our all our doctors will be very clear about what to do and what not to do in these kind of situations when they face with reference to medical termination of pregnancy, because the day in and day out we are doing a lot of MTPs. So
Yeah.
this is first.
So the first case is about termination for major unmarried. Now remember, a woman has a right to become pregnant and she has a right to terminate her pregnancy. So a major woman. So she's a major, she has right to terminate the pregnancy. Yes. But before you terminate her pregnancy, you should get a consent from her that it was consensual sex. That's all. So once she says it's consensual, then you don't have to inform the police. It is up to her and it's fine. In the second case,
so we can add that also, sir. Elaborately we can write it. This is out of consensual sex, and I don't have any problem with anyone, and I am not going to go to the court or sue anybody, file FIR, and I am not interested in informing this to police, all these things,
Police,
because
yes.
too many cases are about this, and there is one more case in Tiruvannamalai also.
Yes.
So that is, yeah. So we can get an elaborate thing that I am not ready to, I am not willing to
take
get
any
informed.
action. Yeah, don't inform the police. They themselves say don't inform them, but then it's okay.
That also from her own handwriting will get it, sir.
Yes.
Yeah.
Yes. The second case is very interesting. Minor married. Now, by law, minor cannot be married. Okay,
Yes,
now
sir.
it is. So a minor, when she's not married, she doesn't have right to become pregnant also. First, so a minor cannot become pregnant, and when she cannot be pregnant, this termination also is a thing which you have to be very careful. Now, a minor, the state takes it is a citizen of the patient. The person minor is in the control of the state. The government takes control of this minor's health. So therefore, you have to be very, very careful when you're treating a minor. Nothing should go wrong. If the minor is injured, nothing, the state will come heavily on the doctor. So remember, when your documentation should be very, very clear that minor means POXO will come into place. Immediately inform the police.
Yes.
Inform the police. Now they'll come and tell you, I want termination of pregnancy. A minor has the right to get terminated provided the guardian is giving the consent. So if the guardian says, please don't inform the police, it's because she is married, then you can say minor cannot be married. If you think she's married, go to the court, get a court order. That's it. That will save you. The court will decide is the marriage legal or not. Certain communities, it is legal. Once they are attend puberty, sir, their law will allows them to get married. So if they can prove in the court that their personal law overrides the state law, then the court decides and they'll give the permission. You can be safeguard yourself. But tell them to go to the court. But termination of pregnancy is different. You can go ahead with termination of pregnancy, get full requirement from the guardian's consent for termination. The third one is very, very important, minor unmarried. Here, you have to help the police find accused. Who is, because minor unmarried means there's a third person who's done a crime. So the criminal you should help. As in our previous talk, they have mentioned that one of our duties is to help the law enforcement catch the accused. So therefore, minor POXO will come into place. We are supposed to inform the police. You inform the police. You can go ahead, do termination, collect the sample, give it to the police to get accused sample and match. So therefore, DNA matching, all that can be done. So it is duty of the police to catch the accused. But documentation is very important.
Even if they are not willing to inform the police or whatever it may be, we have to inform.
Yes, you have to inform.
Even if they deny treatment, if they even leave us, we have to inform police.
You have to inform. Unmarried means you have to inform. Married minor, yes, you have to tell them to go to court and get court order. That is
less than 18 means we have to inform.
Inform. Minors, you have to inform.
Inform.
Yeah. So the answer, sir, so we have a married minor and they are going to go to the court to get the whatever they want to do. And we have not informed any authorities. Will the authorities come down hard on us, sir?
No, you have to.
According to POXO, it is our duty to say that.
Minor means you have to inform.
You have to inform.
Whether married or not married, we inform.
You have to inform. POXO will come into place. You have to inform. But then if they're married, the police don't have to catch the accused because they're married.
So they have to go.
So they have to go, So they have to go to the court and say accused is actually a husband. So they will, police is left off their duties.
Unfortunately, these cases we are getting in the heart of Chennai, sir. That is minor, married, all these things.
Yeah, it happens. It's after then they have to go to the court and get the order.
Sir, minor.
We are running short on time. We'll have one last question from Dr. Geeta.
So, patient and attenders, usually they come to the consultation room with their mobile camera facing us, sir. In the pocket of the husband, it is always facing us. Should we ask them to hand over the mobile in the reception and ask them to
come?
Yeah,
Will they?
this question I also have faced. I'm telling you, this is happening today. It is happening and it's a reality. We have to accept it. First thing is you have your own right. You have a right to protection. So you should first ask them if they are shooting the camera, first ask them if have they taken your permission. Patient has to take permission. Now, if you are also taking the, if you are also having CCTV in your consultation room, first of all, you can't have it in the examination room, 100%. But if you are having it in your consultation room and just talking, you can also record that thing. But before you record, you must take permission of the patient. Same way, vice versa. The patient also has a right to take recording. But the recording, you should take with permission. Everybody has a right. But provided you inform the other person that you're doing. Doing stealthily is wrong. It is not
Yes,
ethical.
we can put it a board outside that is recording audio, video is without permission is prohibited. Like that, prohibited. And even if it is done, it cannot be used. See, we had some other similar situations in government. In that situation, the audio recording done by the government official as a part of an inquiry was not allowed to show it in the court because the permission was not obtained from the person. So we can clearly write it down outside our clinic. Audio and video recording of the consultation should not be recorded without permission. And then if it is recorded without permission, it cannot be used. The patient can be sued like that. Patient can be sued. Patient can be sued like that.
Yes.
Whether it is useful or not, at least to some extent.
Some fear will come in. Yes.
And second thing, if they use it later without our knowledge recording, we can say that it is done without our permission. And we are ready to give
ground for us to put it on the opposite side. We can sue them for that.
Yes, because they cannot use it. The very first, if they start using that evidences, we can say that they have breached my privacy. I am a female doctor and blah, blah, and I am working and anybody cannot be recorded. And I have written clearly in my clinic and they have accepted all these things, we can say.
Yes.
But we cannot ask them to keep mobile and come inside, no?
That if you write this in front of your clinic, that
like if they don't object, what can they say? We already a lot of us
Madam,
that they
lot of hidden cameras, ma'am. This mobile part is not.
Mobile is very small. You can have it every
a lot of hidden cameras, audio, video. That is why the camera, this mobile part, asking them to keep mobile camera is not going to have any use. That is why we are suggesting that to give it in the writing and outside. So that it is very vivid. And if they do it by any means, whatever may be the mode of recording, whether it's voice recorder or whatever it may be, they cannot use it because they have not got your permission. That's how.
They will never ask permission, madam.
No, madam, they do. Ma'am, they do.
Yeah,
madam, the wife comes and says, I'll keep this phone here, doctor. My husband will go home and ask me everything. I have to give him answer.
Yes, correct.
I prefer it. They have taken my permission, put it on top, we'll do it.
Yes, that is why with the permission, without permission word is there. So if they do it without your knowledge, if they use it in the court or any other places, you can simply say that I am allowing my patients, if they ask me, provided the husband is not unable to come or whatever the situation. So in this situation, they have not got my permission and it's breach of my contract. All these things we can say.
Yes, because many things they will not understand at that point of. They say, we want to recollect what all you said, so therefore I'm recording for that purpose. If they say there's no problem, that's
I'm telling this point just to be on the something is better than nothing. That in that way, it may not be 100%.
When we talk to the patient, we have to be double, triple careful about the words we use, what we talk, because at any point of time it can backfire on us with or without recording. So even if we say that they are recording, we are not going to say anything inappropriate. Being conscious that it's recorded, but still what you said is a good choice, ma'am. How to overcome it.
Yeah, thank you.
And I think we've had a very diverse kind of questions and all day-to-day matters which we usually face in a lot of OBGYN OP and the IP setup. I really take this opportunity to thank our moderator Vivek Madi for giving all practical tips and practical points how to go about certain cases, and the panelists for giving all the questions. Though we started yesterday, I think we were able to bring out a lot of questions, very useful questions for all of us. Thank you very much, sir. Thank you very much.
Thank you, sir. Thank you, madam.
Thank you for the opportunity, ma'am.
Thank you, Gayatri. That was a fantastic reverse panel. And thank you, Dr. Vivek Madi and all the panelists for firing Dr. Vivek with all the practical questions that needs some real legal help. And I thank all the delegates and the faculties for having participated in this.
Yes, ma'am.
Thank you, Ramani ma'am. Thank you, Sambat ma'am. Thank you, Vivek sir. Thank you all.
Sampat
Thank
ma'am,
you.
quiz questions?
Sakiti, you can project the 2 questions.
Yes, ma'am. Can you see the questions, ma'am?
Yes, which is one of the most important thing in avoiding medical legal suits, mob reactions. Documentation, communication, treatment, prayers. Only delegates, I think most delegates are left, given the faculties can do. Whoever is answering first, we will be given that prize.
Communication.
In the Google form. Okay.
It's good panelists cannot participate, madam.
No problem, because many people have left it. Now we
Yeah.
are only 19 of us are left. So I thought we will do it. The documentation to be preserved for MTP Act is for 3 years, 5 years, 10 years, 1 year. This was answered by Dr. Vivek.
We are not able to vote.
Yes, ma'am. Timer.
Okay,
answer,
Sakiti. So in the meanwhile, Dr. Gayatri, our MOC, will deliver her vote of thanks. After the vote of thanks, we can see the winner. Yes, Gayatri. But Sakiti, அதுக்குள்ள ready பண்ணிட்டேன்.
Okay, ma'am.
It is a great pleasure to be proposing the vote of thanks for this wonderful CME the webinar, for which all of us were able to sit in our comfort zone and then attend and gather so many important information about a very neglected but a very, very important topic of today's practice, the medical law and all those things. I really thank our president and secretary for thinking about this topic and getting all the experts into it, so that it was really useful for the delegates, for a lot of take-home messages for our delegates. I thank our chief guest, Dr. Lakshmi Srikande, for coming and joining us on this forum and blessing our CME and giving her words of advice. My humble thanks to our expert, Dr. Jitendra Sharma. He is very well known in the legal arena and for giving all those practical tips, how do we go ahead and all those things. And Dr. Vivek Maddy for giving practical what to do on the point tips and other things. Panelists, a great congratulations and thank you for all of you for pulling in your questions. Very beautiful questions and very practical questions. I also like to thank the Shield people for this platform that they are giving us and helping us throughout these years. And I request you to proceed and give us the same kind of platform so that more and more number of people can be, can benefit from all these CMEs. The delegates, thank you very much. The CMEs success depends on how many of you take it. So thank you very much for taking your time and logging into our program in good numbers. And my humble thanks and prayers towards the God Almighty to keep this running and to keep us all safe from medical legal suits. Thank you.
Thank you, Gayatri. Dr. Vivek, there is one question in the question answer chat.
Yeah.
What about premarital conception, minor at the time of conception, now major?
Yeah, at the time of conception, it's minor. Minor is we have to inform POCSO.
Yes, it comes under POCSO. Dr. Nitya, this is the answer. Okay, thank you. It was wonderful. Dr. Sakiti, are you ready?
Yes, ma'am.
Please post it.
என்னோட அடிக்கடி கேட்டேங்கம்மா, நான் அம்மா பர்மிஷன் இல்லாம தரமாட்டேன்னு சொல்லுங்க.
கொடுக்காதீங்க.
Yes, first question is Teresa. Teresa is from which place? Mobile number they didn't write, Sagiti.
I will update, ma'am. I will send you again.
Teresa, ma'am, from ESI.
Teresa is ESI. Okay. Then Malini Kannan. malinimurthy@gmail.com. I don't know. Both of you, that Shield people will come to your place. Please.
Malini from Dindigal, ma'am.
Malini from Dindigal. Okay.
Yes.
You get the mobile number and we'll give to Ganesh.
Okay, ma'am. Sure.
Thank you.
Thank you,
ma'am. Thank you.
Thank you, ma'am.